line में
but
से शुरू हो
last
जाती
out,
है.
sir. Mahipal sir, first in but last out. You cannot go out before we end.
So we are like,
Okay.
who is second?
So you can go second, sir.
Okay, fine.
So, good evening, everybody, and welcome to our webinar on the refractive surgery mystery cases, a case series. Welcome from the Scientific Committee AIOS, and we have with us a very enlightened group of speakers, panelists who are going to resolve the mysteries of refractive surgery case files. Thank you for joining with all of us, and we are in for a great webinar. Thanks to the AIOS Governing Council for all their help and support. Our team members, Dr. Amit Porwal, Dr. Fairuz, Jatinder Singh Bhalla, Krishna Prasad Kudlu, Parikshit Gopte, and Somshila Murthy, and Sonu Goel. Our chairpersons, we have Professor Jeevan Tithyal sir, Professor and Head of Cornea, Cataract and Refractive Surgery Services, Dr. RP Center for Ophthalmic Sciences, AIMS, New Delhi. We have Dr. D. Ramamurthy, Founder Chairman of the Eye Foundation and past President AIOS. Welcome, sir. We have our moderators, the people who have really worked very hard to put this refractive surgery case files and the mysterious case files so well in order. Dr. Krishna Prasad Kudlu and Dr. Sonu Goel. In our expert panel, we have Professor Namrata Sharma, Secretary AIOS and Professor of Ophthalmology, Cataract, Cornea and Refractive Services at RP Center, AIMS, Delhi. We have with us Dr. Rupal Shah, Clinical Director of New Vision Laser Centers, Vadodara and LaserX Institute of Laser Medicine, Mumbai. We have Dr. Gaurav Luthra, Director, Drishti Eye Institute, Dehradun. We have with us Dr. Kumar Doctor, CEO, Dr. Eye Institute, Mumbai. We have with us Dr. Sujata Mohan, Executive Medical Director, Rajan Eye Care, Chennai. We have Dr. Praveen Krishna Vadavali, Director, the Cornea Institute, Head Refractive Surgery, Cataract and Contact Lens Services, Consultant, Cornea and Anterior Segment Service, LBPI, Hyderabad. We have Dr. Pooja Kamar, Consultant in Cataract and Refractive Services at Narayan Netralaya Eye Institute, Bangalore. And with this, I would request a word of welcome from our President, Dr. Mahipal, followed by Dr. Tithyal sir, and then by Dr. Ramamurthy sir.
Thank you very much, Dr. Partha. Pleasure being in this webinar on the mysteries of refractive surgery. I think refractive surgery is one of the fields that has grown leaps and bounds over the last few decades, I would say the last 2 decades. And it is the second most commonly performed surgery today after cataract surgery in ophthalmology. Obviously, what I heard was that intravitreal injections are now, numbers are increasing and maybe they are more than the cataract surgeries, but refractive surgery is something that has actually evolved very significantly from the radial keratotomy days, which was several decades ago, which was reasonably inaccurate as regards the outcomes. Precision and accuracy and great outcomes are something that we look upon in refractive surgery, and there have been several modifications from how it started with the PRK procedure that is there to make it more predictable, more safe, and better outcomes in most of the cases or almost all of the cases. Obviously, if and when something goes wrong, whenever you are doing a surgery, there is a possibility of the tissue misbehaving or some function of the machines going wrong. That hurts the ophthalmologist, and because we are dealing with good eyes, apart from the fact that they are having refractive errors. So therefore, I think what you are holding just now is a great session where we will be talking about how outcomes can be made more precise and certain perspective cases and outcomes that various people will discuss. And obviously, you have put forward a great panel who would be discussing and presenters. And I think the scientific committee, as I have been saying, is doing a great job. All your members, as also you, in bringing out pertinent topics and keeping the education and scientific content for all the members alive. So I think all the very best for this particular webinar, and pleasure as always to participate. And refractive surgery needs to be known by majority of the ophthalmologists in today's era.
Thank you, sir. Thank you very much. Tityal, sir.
Yeah, thank you, Partho, for organizing this webinar, which is so important. I have a similar views which Dr. Mahipal Sachdev had just said about this refractive surgery webinar. And I'd like to really put my congratulations to entire scientific committee team headed by you. And this has been a wonderful series organized by you people. And I'm looking forward to learning from the experts who are there today. They are, I think, the masters in the refractive surgery panel. They are one of the best teachers available in the country. And the people who are going to join us today, they'll definitely benefit with the panelists we have today. And I really look forward to learning from these masters myself. And like to welcome the entire country and the people who are joining from abroad also for this refractive case series. I'm pretty sure it's going to be a wonderful session for next 2 hours for us. Thank you again.
Thank you very much, sir. You are the master of the masters because you are the chairperson of the session, sir.
That's why we are chairperson. That's why I'm going to learn much more than the people going to talk about the various things.
Dr. Ramurthy, sir.
Thank you so much, Dr. Partha, and the rest of the scientific committee members for this very kind invitation. You people have been doing an excellent job bringing about a series of wonderful webinars, and I think it's been a very illuminating. And I think today we as refractive surgeons are spoiled for choice, and both our patients and we have the freedom of choice to pick and choose what's best for each one of our patients. And that lays the onus on us to make the right choice. And I think there's sessions like this, which goes into the intricacies of the field. And as was pointed out by Dr. Tityal, we constantly keep learning from these sessions, and there's no end to it. I'm also looking forward to a wonderful session and going back much better informed than what I started out today evening. And I find that any number of sessions you attend, there's always something extra that you gain from this. And I'm looking forward to this. I hope all of us enjoy this. Thank you.
Thank you very much, sir. Dr. Namrata, would you like to say a few words?
Thank you, Partha. Thanks one again for organizing this webinar. And it's a mix of, the speakers are a mix of experience, as well as we have some young ophthalmologists here. And we have experts in this field as well as international speaker. So I think we are going to have a great session. I think we should move ahead without, much ado now.
Thank you very much. So over to our two moderators, Dr. Krishna Prasad Kudlu and Dr. Sonu Goel, please.
Thank you so much, sir, for a wonderful introduction. It's indeed a great pleasure for me also to in between the doins in the refractive surgery, doins in our field of ophthalmology. Of course, without wasting much time, I think let us start with our first speaker, none other than the president of All India Ophthalmological Society, Dr. Mahipal Sachdev. To introduce him, I just hand it over to Dr. Sonu Goel.
Thank you, Krishna. I think the topic, the mystery cases, is all what we'll be dealing in the next 2 hours. And it is none other than our own president who will be speaking on the mysterious smile. So let's see what mysterious smile sir has to give to all of us. And it's a pleasure to welcome Professor Mahipal. Is my slide visible, Krishna?
Yeah.
So Dr. Mahipal Sachdev is the president of All India Ophthalmological Society. He's the chairman, scientific committee of the IRSI. He's the chairman and medical director of Center for Sight. And he was honored with the Padma Shri Award, which is India's the highest civilian award, in 2007. He's a renowned ophthalmic surgeon, recognized for his expertise in the area of corneal, refractive, and cataract surgery, both nationally and internationally. He is widely credited to be a pioneer in India in propagating the technique of phacoemulsification for cataract, smile, and all arena of refractive surgery across. So I think he is among the top surgeons worldwide, the most wanted. So all to you, President Sir. Thankful for making for us.
Thank you very much, Sonu, and thank you again. I'll be talking about the tips and tricks of SMILE. So essentially, it's going to be a talk on how to get your outcomes good and where all you can go wrong and how do you get the right results. Is everything there?
Yes, sir.
Yeah, okay. So when we are looking at outcomes in refractive surgery, as I was talking in the introduction, that we have moved from conventional LASIK, which was where we were using a microkeratome blade to create a flap and using an excimer laser to reshape the cornea. And then in 2006 or 7 in India, there was the introduction of blade-free LASIK, that is the femto LASIK. And that time it was the FS60 that was there. And over time, there have been improvement in the femto procedure also. But the biggest revolution, I would say, that has come is the use of a single step procedure that is called a SMILE, where we have reduced the flap, which is a 22 millimeter flap that is being created, to an incision which is only 2 millimeters. And it has become a single step procedure, wherein instead of photoablating or burning corneal tissue, we are instead creating a lenticule with a femtosecond laser to carve out the cornea in the methodology that is there. As of now, clinically, we still don't have hyperopic corrections that are available, but it is going to be possibly available pretty soon, maybe within a year's time, that is there. Now, when you are looking at the SMILE procedure, there are 4 steps to the SMILE procedure. The first step is essentially you have the bottom of the lenticule, and then depending upon the thickness, this is an aspheric profile. You create a side cut, and then you have a cap, and then you make the 2 millimeter or 3 millimeter side cut that is there, which is called as the cap opening incision. So there is a contact interface, which is a gentle contact interface, which is 360 degree, and it is not a hard dog that is there. So there is minimal applanation, and the curvature or the surface of the cornea is very well maintained with minimal intraocular pressure. There is no vision loss during suction. It is only when the OBL layer comes into the center that there could be a loss of a person seeing the green blinking light that is there. Now, the corneal fixation assures a better fixation than the scleral fixation only, and gives you a precise treatment positioning with low suction pressure, minimal applanation, and minimal IOP increase that is there. And this you can see is the cross section of the contact surface that is there with small holes, which gives you a 360 degree suction that is there. Now, the duration of treatment, what is very, very important is that you have to set the laser parameters as per the machine. And that is something very important, that each machine behaves a little different, and the amount of energy setting should be reduced to the optimal level, where you don't have like a Christmas tree OBL or you have cold spots. So therefore, the setting has to be great, and that needs to be individually done for each particular machine that you are using. Now, the treatment is independent of the power corrected. That is something very, very important. It is only the thickness of the lenticule that is going to be different. And it is not that if you are treating a -1 or you are treating a -10, as in the case of excimer, the time that is taken would be in the 20 seconds, 23, 24, 25 seconds, depending upon the optic zone that you are creating for that particular patient. The workflow is superior, and there is no influence of the environmental factors and stromal bed hydration or humidity of the operating room. So this is a standard procedure that is done, wherein you can see that this is the green blinking light that is there. You can see that the pattern is reasonably good in this particular case. And this is the posterior surface of the posterior lenticule. This is a 360 degree side cut that is happening. And this is now the cap cut, which is there. And there is the side incision that comes through which you are going to take away the lenticule. Now, once the suction, the machine, there is audio command, and the machine automatically leaves the suction. So what you have to do is you bring the patient into the microscope. That again is a great feature, where once you have the person coming down from the patient interface towards you, the microscope light automatically switches on. And these are the 2 planes that you have to dissect. This is very, very important. For everybody, the best way is to go on the anterior plane. As you can see, this is on top of the lenticule, and therefore, if you go to the bottom of the lenticule, the lenticule would stick to the upper part, that is the cap, and it becomes a little more difficult. And I'll talk about the dissection difficulties that you can have. So once you have separated it out, you can see at the time you have gone above the lenticule, you will not be lifting up the edge. Just watch here very carefully. You can see that there is an edge lift. Can you see there is an edge lift? This shows that you are posterior to the lenticule, and that is the second step that you have to do. Go back in the posterior to the lenticule, and you do not separate from both the sides totally, because otherwise it tends to just roll over. So this is the forceps that you are using to take out the lenticule. So this is, you can see the exquisite surgery. It's the most gentle surgery, and this is how the lenticule comes out. And if you want to see, you can put it on there and kind of spread it to see whether the lenticule is complete or not. There is the problem of retreatment. As of now, commercially, we don't have the possibility of a smile being retreated as a smile, but you can do what is called as a circle scan, wherein you can see that the cap which is there is made into a flap. So this is a new cut that is initiated, and I'll just show you for retreatment. But one thing suffices, all the people who are here who are doing smiles, you can see this. This is being coming out. This is the same thickness at which you had the previous cap, and you are working here, and then you have created a side cut. There is a donut kind of circle scan you have got, and this is the place from where the previous lenticule was removed, and now you are doing an ablation and bring it back. The flap is being put back, and this is like a fresh cut. So the chances of epithelial ingrowth are much less, or it is as much as a new flap that is there. One thing which all of us who have switched over to smile have noted, that the incidence of retreatment is much lower than you had with the eczema. So there is no risk of epithelial ingrowth, and smile then LASIK is actually safer than LASIK after LASIK because epithelial ingrowth does not happen. Now, there are certain possible challenges with smile, which I will be discussing as regards the mystery, and these are the challenges that have been written. The intraoperative and the postoperative, I'll be dealing mostly with the intraoperative challenges. Just to tell you that whenever you are using a femto, if you have an interface debris, which you can see here, this is the cilia of a patient who's having an interface debris, there will be a cold spot. If there are minor threads, etc., fibers, I mean, then there is no problem. But in case you have a cilia, it is prudent that the laser should not be fired and the cilia has to be removed, because you will get a cold spot, and it becomes a little difficult, as you can see here, to separate it out. So this is one of the things that one has to be very careful. Now, the second thing I will be talking about is suction loss. Suction loss basically is a problem because the duration of the laser is slightly more than what you have in a flap. If a flap can take 12, 13, 14 seconds, this is going to take about 23 to 25 seconds. And also the suction is more gentle. It is not a tight suction like you have in the intralace. So there could be a loss of contact, and it depends on what level you are having a suction loss. If you have started the procedure and the suction loss is less than before 10% of the first section has been happened, the machine will automatically go and restart. If the lenticule cut is happening and you have crossed the 10% limit, then there is no other way but to convert it to a femtosecond LASIK flap rather than trying to do a smile at that particular time. If there is a suction loss during lenticule side cut, then you have to repeat from the side cut and decrease the diameter by 0.2 to 0.4. And if it is during the cap cut, which is there, you repeat for the cap cut using the iris recognition register for the infrared for recentration that is there. And if it is during the side cuts, you repeat only the cap side cut by decreasing the diameter. So let me just show you various places where the suction loss can happen. You can see in this particular case, this is happening you lost suction. So therefore, it is at a point where we can only make it into a flap. So this suction was lost when the cut was more than 10%, and therefore we had to make it into a flap. Now, if there is a suction loss which has happened after stage 2, that means it is at the third stage where you are cutting the anterior part of the, that means that the cap cut is happening. You can see this is the posterior lenticule cut that has happened, which is fine. 360-degree side cut has happened. And now you can see that there is a fluid coming here at this particular point, and there is going to be a suction loss. You can actually stop because there is no way you can retrieve. So you stop here and you will go and read off with the same goal. The machine will guide you. You do the infrared for seeing whether it is centered. There in this particular case, now you are starting from point number 3, that is the plane above the lenticule. You can see there is a decentration from the first cut, but it will not matter. And this is the side cut that has happened. And you can go ahead as if nothing has happened, because the femto will go into the same plane as it had when you started. So I'll just go forward. You can see we go into the two planes, and you can easily remove the lenticule without any problem. Now, if you have dissection difficulties, which sometimes happen even to the best of us, but in the learning phase, it is there, that you can see in this particular case. Just see this. There is the edge lift that has happened. The surgeon is pretty sure that he's in the proper plane that is there, and you can see that actually it is the posterior plane that has been entered, and the lenticule will stick on top. So once you are trying to now go into the posterior phase, you are not being able to get. So you are trying to fish it out with the forceps. So you have to therefore go back again and identify the plane. So you can see here we have identified the plane, and now we are trying to do like a reverse capsulorhexis, and we go in once the plane has been created and separate it out. So the key is to be very careful as regards the identification of the planes, and in this particular case, it's the reverse, where we have done the anterior separation later as compared to the posterior, and again you can see that we are able to take out the lenticule as it comes out here. Now, the other thing is that in case there are cold spots which are there, that is going to be a problem. So you have to be careful. Rarely you can have problems. You can see that part of the lenticule has come, and there can be lenticule that can be stuck. You can use triamcinolone tricot to stain it, or you can use fluid, or you can use the microscope. So you see here that there is a part of the lenticule which has been torn. And therefore, even the fluid is giving you the lenticule separation, and OCT will also guide you if you want, but you have to take out the entire lenticule, place the edges of the two parts that are there, and get it out. This is a straight forceps. I don't use a straight forceps, and if you have a straight forceps or any other forceps and you lift your hand up, under those circumstances, you can have a tear. So it really will not matter as regards the final outcome, but you have to maybe put a contact lens and be very careful that side curve extensions do not happen, because it can cause some amount of irregular astigmatism, nothing else. You don't get epithelial ingrowth, but it is very rare that if you push the epithelium in, you can get an epithelial ingrowth in these cases. We were among the first people to report a case of iatrogenic ectasia in these cases. So the parameters that you follow in a smile have to be identical as you have to follow in a flap LASIK, as regards the residual bed thickness, the corvis, etc., and the pentacam topography that you have to do. And we have reported this iatrogenic ectasia, which has happened in one eye of an individual, while the pentacam was all right, and the follow-up of the second eye is still going fine. This has been reported out of Eye Foundation by Gitansha and Shreyas and Dr. Ramamurthy. Sterile corneal infiltrate, as you can see, which responded, which happened. The reasons are obviously not known as to why, but it responded to a course of steroids. So this is another problem that can happen. So finally, I'll just wish to say that there are challenges that happen with smile, but overall, if you, after the learning curve of about 25, 50, 60 eyes, that's what we feel is there. These challenges are rare, but they are manageable without significant or without any visual loss that has happened. And there is no loss of best corrected vision. However, what is important is that you need to have somebody guide you right in the beginning, and you should have appropriate knowledge for management. I think there is some amount of skill set that is required in doing the procedure of smile, and you need some amount of surgical dexterity that is required to give you good outcomes for the patients. So that is what I wish to say, that the limitations of smile, as I told you, hyperopia, no cyclotorsion compensation. You have to do manual marking, as was described by Shri Ganesh, but I think soon we will have cyclotorsion compensation, and new machines that are coming are having cyclotorsion compensation. And there is no smile on top of smile for enhancement that is available just now. So these are few of the limitations, but since it is a new procedure, only about a decade old, these things are going to be overcome very soon, and this is it is going to. So the evolution of refractive surgery is taking us closer to preservation of corneal biomechanics. Dry eye is much less, and smile is one of the latest techniques to achieve this, where there's a fundamental shift from being flapless. So it is flapless and bladeless, as one says, and smile is, at least in our practice, it is the preferred technique, and more than 90% of our patients are going in for smile. And it gives excellent results and happier patients as regards patient satisfaction and outcomes. Thank you very much for your kind attention.
Thank you, Dr. Mahipal, for that wonderful overview of the smile surgery. I would request Dr. D. Ramamurthy and Dr. Rupal Shah for their quick comments.
I think Dr.
Dr.
Mahipal.
Dr. Rupal Shah, ma'am.
Yeah, I thought Dr. Ramamurthy was speaking. So
ladies
let
first.
him
Go ahead,
finish
go ahead.
talking.
Go ahead, please go ahead.
Okay. So it was a wonderful presentation, Dr. Mahipal, and it was quite complete. And I tend to agree with everything that you have said. What I also would like to add is that we are now studying the 10-year follow-up results of SMILE, and they are really very promising. They are showing the same safety, stability, predictability as we had seen on the first year of the SMILE technique. And so it is something that's going to stay. It's not a procedure which is going away, and probably will become a procedure of choice in the near future. So I would in fact encourage everyone to at least learn, see, and conclude for their own self how it is and how it is getting practiced, and definitely include that as one of the armamentarium in their refractive practice. It's a very useful tool, and I would really urge everyone to make use of it. Dr. Ramamurthy.
I think in the short time available, Dr. Mahipal covered almost everything that needs to be said about SMILE. Just a couple of points. Whenever you have a suction loss, even in the most experienced hand, there's a little bit of unhappiness, and you're not unsure of what needs to be done. Please be rest assured the machine actually guides you exactly what needs to be done, and you follow the monitor, and most often you're home safe. One thing I don't do is, even if I lose suction during the lenticule cut, there's a suggestion that we reduce the overall diameter a little bit. I don't do that. Go ahead and use the same PI. And most importantly, there's some amount of OBL that's there. So go with the infrared monitor. That gives you a much better visualization than looking through the operating microscope. And as far as the occasional cases which has residual power, or there is a regression, of course, you have various options, and circle is a great option. We have tried it in a couple of cases, but that comes at a cost. In our experience, we have found that PRK over SMILE also functions equally well. So you could always try that out when you're faced with that situation. But otherwise, I think even in our hands, it's an excellent, I think in the center where we have it, it's our preferred modality. More than giving any great results, which is much better than femtosecond LASIK, is the fact that the patients who undergo this immediately after surgery and the first post-operative day are much more comfortable compared to a patient who has undergone a flawless femtosecond laser. I think otherwise the ultimate results are not only in our experience, but even the studies have shown that are quite comparable.
Thank you so much, sir. Any comments from any of the esteemed panelists or even speakers?
Can I just ask a question to Dr. Ramamurthy? Can I ask a question to Dr. Ramamurthy?
Yeah, please, madam.
It's an excellent presentation by Mahipal. I just want to know, has there been any situation where you could not complete the SMILE on that day and you had to take it up at a later date? Or will you continue to do the SMILE if you're going to do it at a much later date, or would you do a PRK?
I think, right in the initial days, we had one or two situations. It's most important to review your laser passage. Supposing the laser has been complete and flawless and you did not have much of an OBL, even a week later, 10 days later, or gone back again because it was done by a novice surgeon and got the lenticule out. And all of us have shared videos where fragments of the lenticule have been left behind that has been taken out a few days later. And that's the reason I always make it a point to spread the lenticule and make sure it's complete, even though everything has gone off unevenly. And another important factor is, in case I'm in doubt, and if it's a small power and it seems to be a very difficult dissection, I think I've just done it a couple of times. I just go ahead and do a PRK. I feel that that's much safer than going around trying to dig for the lenticule, which is not there, which you find it extremely difficult.
Same sitting or at a later date?
Once I did it on the same sitting, another case on a second sitting. But most often you are able to get the lenticule out in toto.
So, Dr. Sujata, I'll just wish to say that if there are uncut areas which are pretty large, sometimes that happen, like for example, the one that I showed us Celia, but sometimes if you dry, the cornea gets dried. That is the one of the major reasons that is there, that or there is something that happens on the optics or the undersurface of the cone, but whatever, that you are not having a pass that is happening. You can do a PRK, that's the OBL disappears in some time. That's not really a problem. So you can do a PRK, but what you can do is that you can convert it into a flap. There's absolutely no problem in, like in an intralaser, you could rerun this thing. The only thing is that maybe you could immediately convert it into flap and do a femtosecond laser. But if you want to do a smile on top of a smile with these problems, then you will have to wait.
Sir, just one question from my side, sir. Did you
Yes.
had any experience of having a lot of black spots in the interface? Then you really had a difficulty to dissect and just left the case there. Then next you postpone the case for PRK. Did you had any experience?
That is what I'm trying to say. These are the uncut areas, and why you have black spots is the biggest cause is the drying of the cornea. We often overlook that the cornea is dried at that particular time. If somebody is learning, you have put the speculum, you put a paracane and things like that, and the cornea dries up, and you're trying, so you will not get the cut areas which are there. Unfortunately, you cannot do anything much at that particular time. If you're getting a lot of spots, I would say that you could you have to, you by clinical experience, you know that whether these spots are going to make any difference or not. If there are huge large uncut areas, then there is a problem. I still remember Sonu came for a live surgery in a 1 hour in one of the conference in Center for Sight, and there was this thing, and he very deftly handled that. You take the duckbill separator, which has a semi-sharp edge, and you can do ahead and do a lamellar dissection like you do a dissection for doing a LK and things like that. So it depends on the surgical experience that is there, but and on the extent of these dark spots. These dark spots are nothing else but uncut area. So either there is something, there has to be either a dry spot or something that is blocking the laser from coming and hitting onto the cornea. So you have to use your clinical judgment at that particular time, and you may have to abort the procedure if you don't want to do, obviously you don't want to do harm to the patient. If there is a large amount of area which is uncut, then that's what I said, maybe use another cone and you can make it into a flap at that particular time, or PRK as Ram said. But doing a smile at the same moment, if you have a large uncut area, would be difficult.
Just a small tip I want to offer, in the sense that, just before, you want the cornea to be moist, but you want the conjunctival sac to be dry.
Yes.
Just before docking happens, we put a couple of drops of saline or BSS and use a swab stick at the fornices to dry it out. But the cornea remains moist right at the time of docking. And I find that, as Mahipal said, if you have dry spots, that's the reason you get those black spots, which are uncut areas. Once you do this, I think the chance of loss of suction is also less. At the same time, you have a moist cornea.
Just for the people, what Ram has said is that in case you have a lot of fluid around the suction and into the conjunctiva, the loss of suction is a much higher possibility there. So you don't have to, in the best of hands, I would say that the incidence of suction loss may be close to 0.5 to 1%. You still, that those things are possibly not in your control. It has been reported between 1 to 2 to 3% on the suction loss. It could be there. But as Ram said, the machine guides you, and more than 95% or 99% of the cases, you can come out unscathed, even if you have a suction loss.
Thank you so much.
I just add one small point. Yeah. It's also a good idea to put your speculum in only once you are ready to dock and you are quite close to the contact glass, so that the patient can look straight ahead, so your centration will be perfect. Also, your corneal environment will remain constant and not get dried at places, and differential dryness will not occur, and you can avoid these problems quite easily.
Thank you, madam. I think going ahead with the tricky situations in smile, mysteries in smile, I think we have got none other than our superstar, Dr. Sri Ganesh. I think to introduce him once again, I hand over to my co-moderator, Dr. Sonu. Sonu, unmute.
Shri needs no introduction, and Shri is again. Is my slide visible? Sri Ganesh is the chairman and managing director of the Netradhama Super Speciality Eye Hospital, the first NABH accredited eye hospital, main interest, phacoemulsification and refractive surgery, numerous publications, more than 100 live surgeries, and numerous awards, honorary FRCS, honorary Doctor of Science by the Rajiv Gandhi University of Health Sciences. And I think he has huge publications, medals, awards, which cannot be listed here. All to you, Sri Ganesh, for this wonderful webinar.
Thank you, Sonu. Good evening, dear friends, and I would like to thank the AIOS Scientific Committee, Dr. Partha Biswas and Dr. Krishna Prasad Pudlu for inviting me to this very interesting webinar. And then I would be speaking on the mysteries in SMILE on retained lenticule post-SMILE cases and then how to handle them. So is my screen visible?
Yeah.
Yeah. So I am a consultant to Carl Zeiss Meditech, and I've been doing SMILE since 2012 now. 8 years, more than 8,000 procedures. So we have had certain very interesting, challenging cases, and retained lenticule is something which can present as a mystery. And I would like to share with you 2 cases. So, and also the approaches. The first approach is exploration of pocket through the previous SMILE incision. And this can be attempted after the corneal visibility improves, usually a week or so. And you have to review the primary video, surgical video, and you should see that the laser has fired and smoothly in all 4 stages, and the lenticule has been created properly. If it is not, if there are black spots and all that, then there's no point in exploring. And like the previous, like Dr. Mahipal and Ramurthy discussed, you can just do a surface ablation. You should also do an AIOS-SC, which can give you definite clues about the location of the retained lenticule. So let us go on to case number 1. This was a 24-year-old male who was operated by my colleague. I was traveling, and this was one of the visiting consultants. He tried doing SMILE in the right eye. He said he dissected the lenticule and he separated the lenticule completely, but he was not able to grab the lenticule. And he tried multiple times, but he was not able to get the lenticule, so he abandoned it. And then the uncorrected vision was 20/40. Best corrected vision showed some mixed astigmatism, and it was not improving. Patient was very upset. Surgeon also was just starting out with SMILE, so he was also very afraid. And then they were waiting for me. And well, this is how it presented. The topography, you can see the topography was showing a lot of irregularity, inferior steepening. Here you can see that this flattening, and also beyond that some steepening. It's even not recording because here this area was quite steep. And on the topography, you can see that there is a hump here. This was inferiorly. You can see that there is an elevation here. So it was a very irregular cornea. And then we thought we'll take it up for exploration because he had not removed the lenticule. And I'll show you the video. So I opened the previous incision. You can see that. And then went in. But inferiorly, there was something there. You can see that. So I went below and then dissected that portion completely. This is what you see on OCT. And I thought it was like maybe a fragment of the lenticule, but when I removed it and spread it out, it was the complete lenticule. So what had happened is he had dissected the lenticule, but he had pushed it down. So that's why he was not able to grab it with a microforceps. And he thought that he was not able to remove the lenticule. The whole lenticule had crumpled and gone inferiorly, and it was causing irregularity. And this was the resurgery at 7 weeks. And you can see pre-op, this was the topography. It was very irregular. If you look at the irregularity, is 7.2 at the 3 mm zone and 8.7 at the 5 mm zone. Very irregular cornea, loss of best corrected vision. Post-op, you can see that the cornea has become regular, the central flattening. The irregularity index is 1.3, which is normal on the op scan. If it's below 1.5, and patient improved to 6 parts uncorrected vision. So this is, final uncorrected vision was 6/6, 20/20. And best corrected was 2016 with very small cylinder. So this was the pre-op OCT, which showed this hump here. And then post-op, you can see that that has gone. Cornea is very smooth. So exploration can be done in experienced hands, and patient can recover very well, though it looks a little scary. The other option is open exploration with the Circle software. Circle software basically is an enhancement solution for SMILE, and it allows the surgeon to convert the SMILE cap into a flap. And it has where you can plan the following incision. One is the lamellar ring, and second is the side cut with the hinge, and third is the junctional cut, which connects the inner part of the interface. And we used it to treat irregular astigmatism as a consequence of complicated SMILE surgery, and I'll share this mystery. So indications, when would you like to use Circle software for exploration? If there is irregular topography, the AIOS-SC is inconclusive. You can't see anything on the, it looks pretty normal. And even if the AIOS-SC shows multiple planes of entry, you don't know which plane to go into, then that's when you use the Circle software. This was a case of incomplete lenticule dissection to a large, because of a large black patch. And we were discussing black patches. This was a 33-year-old female. SMILE procedure, both eyes, right eye went on very well, smoothly. Left eye, there was complicated surgery because of a black patch. And post-op, the best corrected vision was only improving to 20/40 parts with a myopic astigmatism, -1 with -1 at 125, but she was not improving, only 20/40 parts. The right eye was good, left eye was bad. She was comparing, and she had a lot of discomfort. This is the primary surgery. So you can see there's a large black spot here. Now, black spots can occur because of dryness, because of meibomian secretion, etc. And you can see that the dissection, though we went ahead because it was not in the center, not in the visual axis, I went ahead and did the dissection. You can see there is a little bit of difficulty while dissecting at the area of the black spot. But I complete the dissection, I'm able to remove the lenticule, I inspect the lenticule also, and you can see that the whole lenticule has come out. And you can see, so this is a mystery. The whole lenticule has come out as such. And then, but the topography showed this picture. There was a central steepening here. You can see this area was steep. It's like a central island in the old LASIK machines, what you used to get. Central steepening and irregularity in the center, loss of best corrected vision. We did the AIOS-SC also. If you look at the AIOS-SC, it was unremarkable. I mean, you can see the interface here. There is no lenticule as such. We couldn't make out any remnants. If you look at the epithelial maps also, kind of unremarkable. You can see there is some amount of thinning of the epithelium in this area, but largely okay. And if you look at the pachymetry map also, it's fairly uniform. So what to do? And we were wondering what to do, whether we should do a topo link for this patient and treat that central area, which is irregular. Then I decided maybe the irregularities in the interface. So if we treat the surface, it may not really help the patient. It's better to explore and treat the interface. So on slit lamp examination, I could see a small ridge like that here. You see this area? So that was there on retroillumination. So that's why we decided to use the Circle software. So this is the Circle software where the cap is converted to a flap. So the nasal hinge, I lift it up and you can see there's a sliver of tissue there. Can you see that? So as I'm just pushing, there's a very thin, maybe like about 10-15 microns tissue, which is stuck. So it is part of the lenticule was stuck and the whole lenticule has not come out, but a part of it, maybe like 10-12 microns was left. And that's a very thin area. You can see it was very thin, small piece of lenticule, which was sticking right in the central area. That's because of the black spot. And after that, I just did a PTK, like a 30 micron PTK, just to smooth the surface, put back the flap and put a bandage contact lens. And this was the results. This is the pre-op topography. You can see the central steepening, and post-op you can see it is regular, and you see that central flattened area. And uncorrected vision was 20/20 parts, and patient was happy. So this is again, if you have a very small sliver, then it's very difficult to go in through the pocket and dissect this. You can't make out, even if you use triamcinolone, it may be difficult to kind of remove it when the pocket is there, but when you lift the flap, then it's easier. And this is the post-op clinical photography. You can see that it is very smooth, the interface, because I've done a PTK also. And we have also published this in JRS, Management and Outcomes of Retained Lenticules and Lenticule Fragments after failed primary smile. And it's a case series where we have put in different cases. And the video also is there under therapeutic refractive surgery if you all are interested in going through the details. So those are my two mystery cases of smile. Thank you very much for your attention. If there are any questions, I would be more than willing to answer.
Thank you, Shri, for those wonderful presentations. I would like to invite Professor Dr. Namrata Sharma and Dr. Kumar as the discussants. Namrata, ma'am.
So I think Shri Ganesh, very nice set of cases and the mysteries were solved. The first case had a retained lenticule, and of course, as is advocated, you have to do anterior segment OCT if you have it, or alternatively on the same day only you can address it if you have an intraop OCT microscope, because that will help you to delineate the retained lenticule in the interface, and you would know exactly where it is left. And like you said, that it was not a retained incomplete lenticule, but it was a retained complete lenticule. Another alternative, of course, this was done by a surgeon who's in the learning curve, but other alternatives also can be tried. For instance, triamcinolone can be put, or people have used even BSS. And one more thing that can really help, especially when your lenticule gets folded, is air. So if inadvertently sometimes air goes in, or even you can use sterile air, you can actually see the edge of the folded lenticule with the help of
Basically, there are three approaches for beginners if you want to identify the lenticule. One is always dilate the pupil. Dilate the pupil and take the patient on a microscope which has coaxial illumination. So if you have a fundus retroillumination, then you can see the margins. So that is one thing, dilate it. Second is you can use triamcinolone or even predacetate drops. You put it in the interface, it will stain the edge of the lenticule and delineate the lenticule, and then you can dissect it. Third is you can use air. If you put in air, then that air kind of accumulates at the edge of the lenticule, retained lenticule, because it's elevated there, and that will help you visualize. Fourth is you can use the slit lamp on the Visumax itself. So with the slit lamp, you can get a better view. And fifth is you can use an endo illuminator. This is also something that you can use. You put off the main illumination of the microscope, and then you put in a fiber optic at the limbus, and then you can see because of the sclerotic scatter, you can see the edge of the lenticule, and then you can dissect it. We have described this also. Of course, if you have access to AIOS-SC, then it helps. So I think many of the surgeons would, So these are basically the techniques for
tricks of identifying the retained complete or incomplete lenticule have been discussed. So very nicely managed case. About the second case, I would just say that astigmatism, that central island that you saw, even when we do lamellar grafts and we dissect manually, then also that irregular astigmatism is there. And so that is why it was there, and it was, it just highlighted the fact that the dissection is irregular there. So whenever you have a black spot, which is big enough, and you force your way through and dissect them manually, then this is bound to occur. I mean, it is forgiving for small amount of dissections, but not for the amount of black spots that were seen. So, and of course, very nicely through the circle, you just took out that part which was retained again, which did not get picked up on the AIOS-OCT because of the resolution of the AIOS-OCT, which is not that much to pick it up. But again, very well managed. I have one question. In your series of smile surgeries that you have done, what is the percentage of retained lenticules complete or incomplete by experienced surgeon vis-a-vis by surgeons whom you are teaching in your setup?
See, I have had only 2 cases of retained lenticule which I managed. The second one was the case which I did, and the other one was there was a very thin low power and thin lenticule, and then there was OBL at the periphery. So there was a peripheral lenticule, but I identified it with a slit lamp on table itself, and then I was able to dissect it. And then After that, for very thin, low powers and thin lenticules, I kind of add and keep it at minimum 20 or 25 microns thickness so that it's easier, especially if you get OBL at the periphery, then that can make your dissection difficult. And after that, I've not had any. We have had quite a few cases referred to us for retained lenticule, and we have managed about 5-6 of them. There are few more very interesting cases, but because of the paucity of time, I couldn't present all of them. I just presented 2 of them and technique of management. So this is, in fact, I have one more doctor who got operated in London, and he's actually in Singapore, and he's just waiting for the COVID situation to get over. He has, I think, a retained lenticule. He had sent me all his case reports, so I asked him to come, and I'm going to explore and then remove the lenticule. Because one of the approaches that many surgeons would advocate is to do a surface TopoLink PRK. But I think this is the wrong approach, because there is a problem in the interface, and if you don't actually manage that and you're just doing a surface treatment, then that's not going to remove the irregularity completely. You may kind of regularize the cornea a little, the epithelium will compensate for it a little, but if there is a thick area of lenticule, then definitely the interface, there are going to be a lot of scatter and irregular astigmatism, and the patient is not going to be happy. So you need to kind of, primarily, if you can, explore and remove it. If the whole lenticule is in place, surgery being abandoned, and if you see the video and there is some problem with the video, like a black spot and all that, then don't go in and try to explore, because again, it's going to cause some irregular astigmatism. It's better to do a surface ablation. But if you review the video and if you see that the laser has fired properly, pattern is okay, then you can go in and then explore and remove the lenticule.
Shri, excellent presentation, and I think you answered all my questions, that you need to dilate the pupil, and Namrata said that it's better to do an online OCT, then you get a better view. What I wanted to ask you is that when we do all these dissections, I've realized that when you do more dissection, the visual recovery is not as good as what you do normally. So normally patients are 6x6 next day and everything is fine. There was a controversy, if you remember last time, that patients are 6x6 or not next day. So I know that if everything is very smooth, they are 6x6. But when you have to such a thing and you have to re-dissect and everything, so I just want you to bring to the notice that yes, that in such cases, what is your line of treatment and how much time do they become 6x6 or they never become 6x6?
See, if the surface is irregular, like the second case, because there were black spots, I knew that the surface would be irregular. So I combined it with a PTK, a 30 micron PTK, and that kind of regularized the surface also. See, one of the excellent tools to evaluate the interface is the HD analyzer, the OCAS, that gives you the amount of scatter. If you don't have an OCAS, then what you can do is you can dilate and do a retroillumination and retroillumination photography. And we have actually graded the interface, and it's published in IJO also, grading of interface. And in cases of difficult dissection, it may take up till 2 months for the interface to heal and come back to normal. But again, depends upon the surgeon and surgical technique. If there's not much of edema, and if you're able to remove the lenticule very easily, then most patients day one also are 6/6 parts or 6/6.
Thanks, Steve.
Thank you. Thank you so much. Any other comments from any other panelists?
See, the only thing that I'll wish to say is that if there is more manipulation, Kumar, what you said is absolutely right, that there could be a little more time for the recovery, but you pump up these steroids and go on to more potent steroids rather than fluoromethalone, and the patients would recover much faster. It's the manipulation which causes, as Shri said, the interface edema, and that obviously is going to be more if you have more manipulation. It's similar to doing more manipulation in a cataract surgery and things like that. So just pump up the steroids and go to more potent steroid topical drops. But
I have a question for Dr. Ganesh. As was mentioned, triamcinolone acetate diluted is a great adjunct. We have published on it also. Truly delineates the lenticule revenant very well. And secondly, in that very interesting second case, he picked it up from the stromal surface. But in my experience, quite often it's stuck to the back of the cap also. So sometimes you go digging around in the on the stromal surface, but you might have to scrape it off the back of the cornea, back of the cap. And thirdly, for Kumar's question, I mean, if it's a small lenticule bed and you're able to remove it completely, which has happened in my hands about 3 times, you find that on the first postoperative day itself, the patient is almost back to normal. And the topography also completely regularizes. Of course, it has been a lot of handling, and many days later, then it's more challenging for the patient to recover the vision.
Actually, in the second case, I used an endo illuminator. I put out the microscope light, used an endo illuminator, and that's how I was able to spot this, because it was a very thin fragment which was there. Of course, it can also be stuck on the posterior surface, but if you look at the laser pattern, the black spot occurred while the refractive cut was being made. So most probably it was on the stromal surface. And most of the time, if during the refractive cut, if you have a black spot or some difficulty, it's stuck on the stromal surface. But of course, you should examine the undersurface of the flap also, and you can remove it if it's there. But mostly it will be stuck on the stromal surface.
Thank you so much, Dr. Ganesh. I think someone referring you the case for retained lenticule, I think they have to send the even video recording of the treatment pattern also, I believe.
Yes. I always ask them to send me the videos, and you have to review the videos. Only then you can see, because if the pattern is not okay, or if the laser has not fired properly, then I would not take up for exploration. So this is a very important point which I made. Always ask for the video, primary video.
Chekitan wants to ask one question to Dr. Ganesh.
Yes, I just had a query, sir. The 30 micron PTK which was done, did it overcorrect the refractive error, or did the patient become plano post-op?
No, there was no hyperopic shift. See, if 30 micron is very small, and PTK basically does not cause much of a refractive shift. So that is not very significant. I just wanted to do a kind of a polishing of the surface so that it becomes a little smooth.
Thank you.
Thank you so much. I think moving ahead with the third talk, none other than Professor Rohit Shetty. So let me introduce my friend Rohit Shetty. Just I'm sharing my screen. Is it visible? Yeah. Dr. Rohit Shetty, I am very much excited to introduce my close friend, Dr. Rohit Shetty, who is a consultant cornea and refractive surgery, and also Vice Chairman of Narayan Nethralaya, Bangalore. He is also clinical and transitional scientist, GROW Laboratories. Also, he is faculty in Maastricht University, Netherlands. Basically, he is a cornea refractive surgeon. I think his special interest in keratoconus and corneal ectatic disorder. He's been practicing a high volume of refractive surgery since almost around 15 years. The one more thing, he's been honored with the FRCS from Glasgow, Scotland, and United Kingdom, and presently he is a FRCS examiner. He's also the chief mentor for the dual academic program PhD clinical fellowship at Narayan Nethralaya Institute, Bangalore, and also Maastricht University. So he'll be talking about something interesting, that mystery of biomechanics and wound healing. Over to Dr. Rohit.
Sir, you have to stop sharing your screen. Okay.
Yeah.
Thank you, sir. Thank you for this wonderful introduction. Thank you, Dr. Parthas, and all the scientific committee team for this wonderful compilation of such wonderful talks, and also the president, AIOS, and the past president, Dr. Ramurthy. My talk is about mystery of biomechanics, wound healing, and more in refractive surgery. So these are my financial interests. I'm not going to go into this part at all, because there have been many talks about the biomechanics. Basically, now it's not just the biomechanics; it's a mix of biomechanics and the topography. And these are, and in Pentacam versions, they're called BAD-D, CBI, TBI, and then there have been many talks about this. So new indices which has come, which is called a stress strain index, which is less dependent on the corneal pachymetry and IOP. This is very useful because my next speaker is going to be Dr. Abhijit, and when he was working on this kind of profiling, the entire deformation amplitude is based on your IOP. And that was a major challenge with many times we would never get a right reading. So let me start off with some few mysteries. The first mystery is things don't match. For example, when you look at these kind of topographies, and this is what we have discussed in the past, this looks classically like a keratoconus. There's no difference at all. This is your, I've used both the maps. I use the maps of a pentacam and also use the map of the MS39, which gives you an epithelial thickness and also the anterior elevation. But when you look at this, as soon as you look at this, your mind thinks that it is a keratoconus. But what happens is your biomechanics is normal, the bad D is suspicious, and your TBI is normal. Now the question comes is, do I trust the biomechanics or do I trust the topography? This is very important because you do see some changes out here. The second question here, again, a keratoconic picture, but your CBI is normal, your TBI normal, bad Ds. Now, what do we do with them? Why do we have this mix and match pictures, which always confuse us? The mix and match picture happens because even today, we are not really seeing the eye as a whole. So that's when we started looking at imaging the collagen. And thankfully, in the last 6 months of lockdown, we've been a huge thrust into imaging multiple things on the collagen. And this is how imaging is done. This is a prototype machine. And this is from a textbook picture of how your collagen is oriented in your cornea. And you can see these are these anchoring fibrils, and which is here. And this is this fibrils. So your collagen, when your cornea is weaker, you can see those blue is less bluer, and the yellowish, which is here, becomes weaker. That means your fibrils are weaker. Let's look at this case now. So same patient who had the normal biomechanics, but a suspicious topography. So we don't know whether this patient has a poor biomechanics or a poor topography. So when we looked at the collagen imaging, it's completely normal. And this is how a normal is. This is our patient. And these are the axis orientation, the type of how the imaging is done. And you can see that exactly the same picture. So what was really the picture here is the biomechanics is actually telling the truth and not the topography. And this has always been the biggest dilemma for a clinician. Why does my biomechanics not follow the topography? Because your topography is not the real picture of what a cornea is in structurally. So to look at the structure, you have to look beyond it. So probably in this case, the biomechanics was telling the truth. We go back to the same picture of the keratoconic eye. Still, the biomechanics was normal, and the TBI and bad D, they are together. They follow the same picture. So the CBI is the only one. The corneous biomechanical index is the only one which looks at it independently of the topography. It does not take too many parameters from there, and it was normal. Now go back to the collagen. Even though this is a keratoconic eye, this patient's keratoconus eye, but still it is normal. It does not follow a pattern of a keratoconus. And this patient has been stable with me for the past 5 years. This is one of the reasons why keratoconus can remain stable without progressing, is because the collagen is extremely strong in them, and they don't really show a collagen of what a keratoconus picture is. And that is one of the reasons why your corneal biomechanics is strong, telling the truth. So when you have this kind of a picture, this TBI and CBI always go with the topography. So if the topography is abnormal, they always are abnormal. So this is very, very important to understand that there is a mix. How does all this help? This is example of one more case, a post-LASIK ectasia. Just because we see a post-LASIK ectasia does not mean that every post-LASIK ectasia is going to progress. This is a post-LASIK ectasia done in way back in 12 years back somewhere else, and it's stable. And look at the collagen. It just matches with what you have in normal. And this matches with exactly what a post-LASIK is without ectasia. So that means that every post-LASIK ectasia need not just be a factor to go in and cross-link. There are a lot of them which could be self-limiting. Even the topography may be showing something. All this comes to the strength, because strength is very important. This is what we publish based on the biomechanics, the smile and the cap. When you do a smile procedures versus a cap procedure, smile definitely has a much more biomechanical strength compared to the flap out there. And that is also very important when you actually think about a smile extra, because when you do a smile only procedure, your biomechanical change is very less. And compared to this, there is an 18-fold reduction in your biomechanics as soon as you do a flap itself. So even if you do an extra, you had to compensate for the 18%, which is not possible with your extra. And compared to smile, absolutely no change in your biomechanics when you don't make a flap. So that is why you get a much stiffer, and this is a new parameter in Corvus, which tells you if your cornea is actually becoming stiffer. And you can say in when you do a LASIK surgery without an extra, and when you do a smile surgery with an extra, there are different parameters which helps you tell you. Coming to a very important part of my work today is about the refractive surgery in this COVID era. One of the major things which has changed is the use of masks. Use of masks has been a very big area of interest for a lot of people. And one of the work which we have started is how does this mask affect the wound healing changes in post-refractive surgery? And this is what we have done. This is the whole schematics about what we have done. See, when you wear a mask, it's your exhaled air, which is carbon dioxide. And this is what causes the change. Our air, what you're breathing, is not carbon dioxide. I'll come to the picture why it is important today as refractive surgeons. I'm not talking from a dry eye perspective. This is a schematic which we are working on about how a carbon dioxide, every time you breathe in, or the mask which you have, the kind of, not the mask we wear, the kind of patients people wear, which is just blocking it, it has to go somewhere, changes hyperosmolality. And all this has a huge impact on every single pathway of wound healing. So if you are expecting that you do a particular procedure and expect that the wound healing is going to be exactly the same, like a PRK or something, it's not going to be the same. This is a simple example of what we've done. Create and same kind of use the human epithelial cells, and these are human epithelial cells. And you can see that induce hyperosmolality, induce oxygen, induce carbon dioxide to that. And you can see that all these cells start dying. These are epithelial cells start dying. These are in healthy person. And if you have to then treat it with multiple drug combination to get back to this stage, which is normal. So what we have done is we have close to 6,000 on normal normal tears of different people collected over time. Now we are trying to go back, collect those people tears again, now that they're wearing a mask, and probably will come out with a different picture. How does this impact? This is what we are trying to work on, is in the wound healing part of it. We are looking at impact of this is more on your epithelium and corneal nerves. These are 3 patients. You can look at that. The nerves are healthy. This is all the corneal nerves. The epithelium is healthy. The meibomian glands are healthy. These are patients where the nerves are abnormal. You can see the meibomian glands abnormal. This is what you are going to get now. When Dr. Mahipal said that more number of refractive surgery patients are going to get, these are the ones who are going to get. They are unhappy with your glasses, contact lenses, the dendritic cells, no meibomian glands, and look at their epitheliums. The epithelium follows what the nerves are. And you do a traditional LASIK on them. What really happens? Most of the nerves don't heal. And here in this page, this is all our own patients. And you can see that the dendritic cells have come, and at the end of it, this is what an epithelium is of these patients. If I go back to this, look at the epithelial healing. And these epitheliums are the ones who will create tremendous amount of epithelial changes which could induce or create aberrations. So what are the things we need to do in COVID times? The most important thing is ocular surface index, contact lens intolerance. Confocal is for the research purpose, and all these other factors. But you have to keep in mind, like we have been discussing, with no financial interest, a flapless surgery is important for a patient who is wearing a mask. So it is not, and when you're wearing a mask today, and when you're exposed to long hours, it is not, the wound healing is not going to be the same. And I have changed my entire protocol for these patients. They have more potent steroids if I'm doing a PRK. I use I use very long-term cyclosporin for them. And I take a lot of doxycycline and all that. And I pre-treat them if I'm to do a LASIK flap-based procedure, because the whole wound healing is completely going to be different. To summarize, this is a work of PhD, one of the papers of Dr. Pooja, and about how the wound healing happens. You have a pro-inflammatory, pro-fibrotic, and myofibrotic. This is exactly what happens as a wound healing pattern is.
It's going on.
So what happens is when
to say 30, but that never happens.
I think
the scientific committee member, they're all elderly people.
Could you mute everybody else, please? Sunil, can you please put everybody else?
I think they're all senior surgeons.
Dr. Somshila, I think your mic is on.
Somshila, your mic is on. Yeah. Sorry, I think Rohit, you can continue.
So what happens
We
is
are all old.
so when we have a lot of inflammation, you can see that a lot of these changes which could have a problem, and this would change the way keratocytes behave. Basically, it's all connected to what a haze is. And the wound healing today, what I'm trying to say is when you wear a mask and today's post-operative will completely different from what we had before the surgery. So we have to probably look at it completely differently. So this is my summary. Poor nerves, poor wound healing, poor epithelium is going to change. And these things, to understand these things, we're fortunate, even though this was COVID time, we were able to bring in a prototype. We've been talking about this for a long time, but this is a prototype in the clinic now, a point of care diagnostic kit. A lot of this haze forming factors, a lot of these inflammatory markers can all be checked. It takes close to an hour and a half now, but eventually when we go commercial, this will all be probably possible within 35-40 minutes. It's just like a PCR test would take 3 days. Now it's going to get you in a day's time. Thank all my team of researchers in my lab for this wonderful work for which I just compiled together. Thank you.
Well, Rohit, quite interesting. I think a lot of questions you may have in this particular talk. I think to start with, I think I request none other than our chairman, scientific committee, Dr. Partha Bishwas, and also Dr. Praveen Krishna to lead the discussion.
Thank you very much, Rohit. As usual, a phenomenal talk, and you open up wonders. You've really been Sherlock Holmes for this session, and for all the mysteries that we have today in refractive surgery. I mean, so little is known about the biomechanics. The more one goes into biomechanics or the healing patterns, the fibroblasts and the cytokines, and everything is so complex that what is one way in which we determine that this patient is going to this level of healing, and that would be determining the options of the satisfaction of a patient, as well as the visual acuity of a patient that the patient is going to achieve. So there is that psychological aspect which you have already elucidated in the past. There is also the mechanical aspect, the anatomical aspect that has to come in, and both together become the scientific protocol. However, refractive surgery is thereby also very forgiving, because the errors that we make during refractive surgery is somehow compensated by the biomechanics, by the healing pattern, and by the patient's visual outcome and the patient satisfaction. So all together, with your experience, Rohit, what would you say is, what is the next level that we have to come to in understanding whether a particular patient with a particular procedure is going to come in and have a satisfied outcome?
I think based on, I think one of the major factors I believe is your ocular surface, because ocular surface health is the indicator of various things which is happening deep in. And ocular surface health, I mean, I always, because this is COVID time, you can link everything to COVID. What happens is, if your body is healthy, it can fight anything. If your body is unhealthy, those are the ones who go into your ICU. That means that if your ocular surface is healthy, you do a PRK of -15, you don't get scar. You do a -1 with a poor ocular surface, you get a dense scar of 100 microns deep. So that is one which is a factor. So the indicators are your meibomian glands, your ocular surface index, your if you have confocal, of course, it's not the standard of care, but confocal microscopy. And now we have the kit. I've been talking about it for a long time. Now it's in my clinic, and we're just waiting to build this. This is a prototype, and you can at least look at now 6 or 7 different markers, which are all going to be linked to one or the other factors. And what happens to your biomechanics, I think, is the next talk, which Abhijit is bringing an AI-driven simulation, which I think he would probably answer. But if you ask me now, it's an ocular surface health is the most important thing to the outcome. And that's why in this COVID time, it is most important to preserve the ocular surface health. So I would, if the patient is, if the patient is having a poor ocular surface, you defer or probably do a smile, because there you are bypassing all these factors completely.
Praveen?
Yeah, hey, just wanted to thank Rohit for always thinking out of the box and bringing out things into the open that refractive surgeons who normally are not linked to basic science also start to think about. So some very interesting thoughts there, Rohit. Do you also think that because of the fact that patients are wearing masks at this time, there is also an increased chance of infection because of the redirection of the breath towards the ocular surface, in addition to reduction of the health as well? And do you think you would like to make a recommendation for patients undergoing surgeries like, say, PRK, to wear maybe a tape on top of the mask so that there is less of an effect of the breath on the ocular surface as well?
Absolutely, absolutely, Praveen. See, what happens is the carbon dioxide is just not carbon dioxide. It's filled with all the oral pathogens which comes out. And especially if your eye is open. So most of the time, we do ask our patients that if you're indoors and you are staying at home, they are not anywhere wearing masks. So anywhere they don't go out if it's a PRK. The challenge is, the patients who are ocular surface inflamed, and you do a LASIK or one of the procedures, and they get all right within a day or two, and they go out, and these people start going work, and these are the people who come back with a lot of irritations. So now my steroid regimen would be milder ones. Now I keep a stronger ones. I keep cyclosporin for 6 to 8 weeks, and I use a lot of sodium hyaluronate based lubricants, because you need a more viscous one. See, earlier we would just use whatever we feel like, but the one picture I just showed, in the paucity of time I was not able to explain. We created the whole experiment using that hyperosmolality and hypercapnia there. And we were able to see that different lubricants were not giving you the same results. So when we use the sodium hyaluronate based ones with, there are a lot of now with the trehalose, because that brings in an autophagy component. So they were actually making the epithelial cells to regenerate and survive better. So these are all important, because if the ocular integrity is maintained, your epithelial cells are going to be a biggest barrier against a lot of this inflammation, and they are the ones who fight it. So like you said, what I do is I tell them to not to go out till their epithelium is healed, and don't wear a mask if they're at home.
Yeah. Thank you for go on.
Can I just ask a question, Rohit? See, all these techniques of biomechanics, whether it's a pentachem or it is, your corvus or it's a aura, all of them are depending on the puff of air which is hitting the cornea. And all of these are image-based techniques. So they kind of do not objectively tell us the strength of, the stromal or collagen fibrils which are there in the cornea, and which is actually responsible for the biomechanics. Even the brilliant microscopy is an imaging method. I mean, it is based on, what rays go in and what rays come out or are reflected. So I think there have to be more robust methods of actually gauging the strength of the collagen or the stroma or the cornea for that matter, rather than, of course, as of now we have only these imaging techniques, but rather than just on the rays which are going in and coming out.
Absolutely, ma'am, because what you are seeing, what you call as corneal biomechanics, is only 50% of what is actually happening in your true corneal plane. You only get 50%, I think less than 50% information you're getting. But there are, even with that 50% information, you're still able to make a lot of decisions today. Even that is confusing. For example, the first case I showed, the cornea looked keratoponic, but the biomechanics is stronger. So these are the cases we have been imaging them for the collagen with our prototype OCT. And we found that the collagen is healthy. That means the topography was not telling the truth, but the biomechanics was. So because we are not connecting all of them together and we are reading all of them individually, I think there is a lot of times we are confused, because each machine is not connected to the other. And pentacam and topographies today have a lot of normal variation which looks like keratoconus, which does not keratoconus. And in fact, I did a PRK for that patient. I could have done a smile or LASIK also for him because it is not related to this corneal issue. His issue was he has a very abnormal looking curvature which looks like a keratoconus, which a mind picks up as keratoconus and a bad D picks up as bad D. But when you really look at his biomechanics and his collagen, both are strong. And I mean, I mean, that is where I think this is answered for Dr. Partha, sir, is that we are in grossly, our surgical techniques, like all of you showed, are extremely good, but our diagnostic techniques, I say, are grossly inadequate to at least look at 20-25% of them who are really not sure which side they fit in. And we have been imaging that a lot of a keratoconus. I showed one image of a patient with post-LASIK ectasia for last 10 years has not progressed. And then till that time, we didn't have the collagen imaging. When I imaged the collagen, her collagen is as good as a normal person. So the eye has somehow, the topography shows us keratoconus, ectasia, but the eye has somehow healed itself by not showing any signs of weakness in the collagen. So if I do a cross-linking on this patient, you'll end up in haze or a scar because the eye is healed. You don't need cross-linking on it. So there are a lot of keratoconus patients also who have a normal collagen. That's why biomechanics is stronger. So it is time that we start really looking at all this completely, at least the group here, that is, we are inadequate in many times with our diagnostics.
Thank you, Rohit. I think I want to.
I just have one.
Professor.
Can I ask a question to Dr. Rohit?
Yeah, please.
I think Dr. Sri Ganesh sir wanted to ask something, man.
Yeah, Rohit, very nice work being done. I always appreciate your research and your team. But this was something that I think I was discussing with you also, because topography, sometimes there can be a lot of fallacies. So we can't go on the face value of the topography. For example, if you have a large angle kappa inferiorly, then it kind of simulates keratoconus or ectasia. I can actually simulate ectasia on when I get my topography done by looking differently, and if I'm not fixating properly, it can show up as an inferior steepening. And this is something that we should look at. So we can't go in by the face value of the topography, because there are still fallacies which have to be ironed out. And this is something where we need to kind of, in fact, I was discussing with you also whether we can have an angle alpha corrected topography, which would probably be more reliable. But then again, these cases which are kind of borderline, again, it is difficult. Of course, with collagen imaging, you're doing the cases, but it would be interesting to see them long term, whether they actually are stable or whether they become unstable. And this is something which time will tell. So it's probably interesting to see what will happen over a period of time.
Dr. Rupal.
Yeah, Rohit, fantastic presentation, also quite thought-provoking. I just had one query. I was thinking that, is it that we've been doing this all wrong all throughout? And if it is so, since so many years, should we not see a really high surge of ectasia? I mean, we don't see that many ectasia, even though we didn't have anything like this to look at.
Absolutely. That is why I'm saying that topography is, in a good way, I'm happy that it's doing, it over exaggerates even the small defects. So today, earlier the placidos would not, but the shine flow would. So when you start looking at the collagen imaging, lots of patients would look suspicious or all healthy collagen. So last 25-30 years, people who don't have a topography, if they're doing and not getting ectasia, it means that the collagen is healthy anyway. I showed you some very beautiful images of keratoconus having healthy collagen. So that is why people never had ectasia, because the eye would heal naturally. You don't need to do any time in most of them.
And Rohit, did you have a situation where the topography looked okay, the bad T was okay, a bad D was okay, but the collagen was not okay? Did it also happen like that?
We have very, very rare, but we have 1 or 2 cases like that.
Okay. Thank you.
Thank you, Dr. Rohit. I need one last comment from Professor Titiyal. Professor Titiyal is here. Dr. Titiyal, sir?
Yeah.
Yes, sir.
what to say? Had such a wonderful discussion, and I had an opportunity to listen to Rohit for so many times on this topic, which is so exciting for all of us to really go into the the matrix of an issue, that is corneal biomechanics, which is going to really play future research wise. And the result of any corneal procedure is basically boiled down to what type of activities we are going to initiate into the corneal tissue. And what he has been telling us, right from the epithelium to endothelium, you have a different types of inflammatory related or regenerative related issues. If we can study those things appropriately, I think we'll understand better in future what would be the outcome of our procedures. I think today, I think it's basically based on we all as a clinician, we are looking for a patient's symptom and trying to treat that, rather than actually correlating that to what changes has happened into the corneal tissue wise. That is what I think Rohit has told us, the various changes, and he has correlated them to the clinical symptoms of patient, and wonderful work is done. And we appreciate those things. And I think there is a mystery of outcomes in a refractive procedure in a cornea that will be solved after many decades of research, which is going to follow subsequently. Wonderful work, Rohit.
Thank you, sir. Over to Sonu. Unmute, Dr. Sonu.
So thank you, Dr. Rohit, for that wonderful thought-provoking talk. And we'll have a slight change in the order. And I would like to invite Dr. Abhijit Sinha Roy for the next talk, Mystery Unraveled, AI-Driven Predictions, AIOS-SC. And for this, I would like to invite my friend, Dr. Bhalla, to introduce him. All to you, Dr. Bhalla. Please unmute yourself.
Yeah, it's my pleasant duty to invite, sorry. Jaideep?
Yeah, we can hear, Bhalla.
Yeah. I think I'll just, yeah. It's my pleasant duty to invite Dr. Abhijit Sinha Roy, who is Chief Scientist at IBMS Labs and is working at Narayan Netralaya Foundation. He has over 80 publications in the field of ophthalmology and numerous conferences he's attended. And his research interest is optical imaging and biomechanism. He's been awarded many notable awards and has many achievements to his credit. Now, without much ado, I would invite Dr. Abhijit Sinha Roy. Over to you, Dr. Abhijit.
Thank you, Dr. Bhalla, and thank you, AIOS, for this opportunity to present our latest work. I'm actually unable to share my screen.
You have to stop sharing this.
Dr. Bhalla, you have to stop sharing, Dr. Bhalla. Yeah. Now you can share, please.
Okay. I'll go to the presentation mode. All right, so today I'm going to talk about our newest work, which is called AIOS-SC, and it's really going into simulating the unknown. And I'm happy, the past, just the immediate preceding talk, this point was raised that, what are the things that are lacking in biomechanics and why we are not able to actually, analyze the collagen more objectively. So one of the big things that has been lacking is that when we look at these devices, obviously these are optical imaging techniques, but you have to also realize that these devices do give us biomechanical information because they are measuring deformation. Okay, they give an image of the cornea as it deforms in response to an air puff. But unfortunately, none of these indices which the machine gives right now have been proven to show a direct link to the way classical biomechanics has been interested for several decades. And that has been a lacune. So when we have all these imaging devices, for example, here we have Pentacam, which is giving you BAD-D and several other indices. And then you have the Corvus giving you CBI, SSI. You basically end up thinking that how do these indices link to the way classical biomechanics has been interpreted in the lab? And therefore, the biggest challenge right now is that we are not able to predict what the post-operative biomechanical information on the cornea would be, because you need that information probably before the surgery is done and not after the surgery is done and waiting for things to happen. So this is where, this is a very good example. And, the topic of smile ectasia has already been touched upon by many of the experts in this session. So, the patient has normal corneal thickness, the CBI is 0, TBI is 0.13, BAD D 0.96, nothing really abnormal, yet the patient ends up with post-surgery ectasia. And what has been lacking is essentially the points I'm trying to make, that none of the indices at this point are working on a patient-specific perspective to link the deformation which Corvus measures to the way classical biomechanics has been interpreted. And I think some of you must have read papers where corneal samples have been taken in labs from either donor tissue or from animal tissue and been stretched on an extensiometer to measure the Young's modulus. But these things cannot be done in patients because these are destructive techniques and you cannot just take the cornea out and put it back. So we have to rely on imaging methods to derive the biomechanics out, and this is what we are hoping to achieve. So in 2018, we published this paper where we showed how the preoperative collagen mechanics can be modeled and related to predict what after PRK and what after LASIK and SMILE the cornea would respond. And we also included advanced imaging features where we could include the post-operative remodeling also that we see at the collagen level in these sophisticated biomechanical models. And this is the paper, so I encourage you to have a look at this whenever you get time after this talk. The question is that these simulations are very sophisticated. They rely on classical mechanics, but none of these simulation tools are available in the clinic right now. Okay, so that's why it's engineers like us who work on this at the background. So we went around designing this tool for use in the clinic, and it involves not only the sophisticated biomechanical tools that many of you must have seen in papers, but also includes some artificial intelligence to make the tool robust on every patient that you simulate. So this is a performance metric which we got with the first version of the software. So on the y-axis, we have the in vivo post-operative corneal stiffness, and on the x-axis is the AI predicted from our software tool. And as you can see, the intra-cross correlation was well above 0.9 in almost all the eyes, which means that, in fact, for a LASIK and SMILE, it was close to 0.95, which means that we can predict the corneal stiffness to within 5% of what the patient would end up with post-operatively. So how do we foresee our tool translating to clinic, which is the AIOS-SC here? So we have the Corvus. From the Corvus, we do this, from the Corvus and the Penacam, we do the simulations via the AIOS-SC, and then we can suggest to the surgeon that no further action is recommended, and therefore the desired surgery of choice would be the for a given surgery of choice, the post-operative corneal stiffness would be within the normal change. So the surgeon can go ahead with the surgery. But if AIOS-SC actually gives an advisory that yes, the corneal stiffness post-operatively would be outside the normative range of what our population normally has, then there is a cause of concern, and maybe there is a cause for a deferment of the surgery. So this is where predictive modeling involving sophisticated biomechanical tools and artificial intelligence along with imaging can help you determine post-operative biomechanical changes real-time in the clinic. So, so we knew that AirPuff was there. There are a lot of computational methods that are existing in the research domain, but none of these are available in the clinic. So with AIOS-SC, we have reached a stage where we can do surgery-specific simulation models. We can show what the surgeon would, what the patient would end up with post-operatively, irrespective of the type of surgery you choose. So whether it's LASIK, SMILE, or PRK. So this is a sample report which the software gives out. So the top, which is a gray shaded, I've just marked off the patient information there. But so you will get the general patient information. The second figure which you see there gives the pre and predicted post-op stiffness. So the two black vertical lines, the one on the left is the pre-op, The one on the right is post-op, and as expected that with the surgery, there will be a drop in the corneal stiffness. The yellow and the green histograms which you see show the normal range of pre-op and post-op stiffnesses that our Asian Indian eyes normally exhibit. So very happy to say that this is probably one of the first softwares in the field of ophthalmology where Asian Indian eyes have been included. And the figure below also shows the predicted change in corneal stiffness. So the black line shows the change in corneal stiffness, which is around 14.34 in this case. And the blue histogram again shows the normative change in corneal stiffness that you would expect in the population of Asian Indian eyes. And last is a small table there which shows the simulation parameters. So with this, the AIOS-MX is a virtual simulation tool which involves sophisticated biomechanics, involves the use of imaging data that you get from Pentacam and Corvis, and actually gives you the corneal stiffness before any surgery is done on the patient's eye. So you can make a more educated decision with respect to which surgery you would like to go with for a particular patient. So with this, I'll just stop the screen sharing. I'll take a few more seconds and show you how the software looks. I hope you can see the software snapshot. So, so for example, this is the simulation window over here. So for example, if you want to simulate SMILE, you select a Pentacam file, you select the Corvis file. Once you select these files, the patient information gets automatically pulled in here. For a SMILE surgery, you will need to enter what cap thickness you want to simulate, what cap diameter, what would be the optical zone, what would be the spherical power and cylindrical power and axis you want to treat, and what would be the epithelial thickness that you would want to include in your simulation. So for epithelial thickness, you can use a number from the OCT. We also have the option, which is quite futuristic here, which is the custom thickness. So some of the newer tomographers give you spatial distribution of the epithelial thickness like the MS39. And if someone has that tomographer, then we can even use the epi profile from that machine itself. And we can basically read the file from the tomographer. So using this simulation tool, we want to put the classical way of biomechanics in the clinical domain at the hands of the surgeon. So you can run these simulations and combine actually sophisticated biomechanical tools with imaging in your clinic. And hopefully, we will have much better understanding of ectasia and possibly even eliminate ectasia for good in the near future. Thank you.
I think that's a wonderful talk and very thought-provoking, Abhijit. I think that will be a new next leap in prediction of ectasia. Professor Tatyal, a quick comment from you, sir. Dr. Tatyal, sir.
Just hold on.
We can have Dr. Praveen Krishna.
Yes,
sir. Yes, sir.
So
Dr.
I'm busy just now.
Okay, please, sir. We'll have Dr.
Praveen.
Yep. Thanks a lot, Dr. Goyal, and lovely presentation and great work, Dr. Sinha Roy. And it probably is going to open up a whole new domain from the point of view of what you would expect post-op. So a couple of quick questions. When you have the prediction of the post-op biomechanical stability or stiffness of the cornea, this is, I'm guessing, immediately post-op taking into effect the changes in the physical parameters of the cornea.
Sure.
I guess another level of complexity would be introduced by biological healing of the patient. So the ectasias that typically occur at variable times post-op as well. So I'm guessing there must be a significant amount of biological factors influencing that as well.
Yeah, so definitely. So the like I mentioned that we hope to ensure that ectasia would be completely eliminated. So the population database was included specifically for that reason, that we have a population database where we are looking at acute responses. So something within a year of change. Ectasia may happen even after that. So once, so the point I was trying to make, the lacunae currently is that this simulation tool is not there in the hands of the clinicians. You need to depend on research labs, on people who are doing this at the back end and who don't understand the complexities that surgeons face at the OPD. With this tool now, everything runs at the back end in OPD. If you have a tomographer, In the software right now, we have included Pentacam, but we do have the options of including other tomographers also. So if somebody has Galilei or Cirrus, even those can be included. It's just a simple programming. But with this tool, whether you want to do finite element analysis, whether you want to include sophisticated imaging that you're getting from OCT, you're getting from Corvus, everything gets combined together to give you that prediction of the post-op stiffness. It's one number. We don't want to confuse clinicians with 10 different or 20 different indices, which has been unfortunately the way right now.
Yeah, one quick follow-up question as well, Rohit. I mean, maybe you can maybe address both together. Is have you seen a market difference in the post-op prediction of the biomechanics between the different surgeries for the same patient as well? Something that has surprised you?
In fact, this was the whole idea of this paper came from the work by Dr. Pooja and Abhijit, which got published in AIOS 1 or 2 years back. We call it the predicted versus the outcome. So I think we both missed that putting up. What happens is the dotted line would be the predicted and the dashed line would be the outcome. And they all match so beautifully. So based on that, this software is driven. See, I would like to take ectasia out of this picture for time being because, today's ectasia's numbers are very few. What is important is for a clinician, for example, a patient comes to you, you're looking at a particular topography. You don't know whether I should do a smile or a PRK or a LASIK. You are worried about which one would cause the least amount of biomechanical change. So for me, this software, when you add in the data, it tells you if you do smile, the amount of biomechanical change would be this much. The amount of smile change, the LASIK would be this much. The PRK would be this much. We have started using, and Dr. Prema also from Shankar Nethralaya started using this as a pilot once. And we can give it to you also in case you want to try this out. Because what happens is, this works on a principle that if you're deciding based on which one causes the least biomechanical change. There are times when I felt that I couldn't decide, and then I felt, okay, smile caused the least change compared to PRK. Then you would do a smile, not a PRK, even though you want to do it. And there are times when you said all the three are equal. Then you would do anything. I mean, you would do a LASIK on the patient because you see, today our version is completely driven by the Pentacam and to some extent the biomechanics. This eliminates just one factor, pulls everything together, including the epithelial profile. And now what we are going to do is in the last leg of adding the progression data, we built, Gairek is one of my colleagues now, he built an AI on 10 years of KC progression. And we are in the last leg. Once it gets published, then that will be added. So you put a topography, the machine AI itself will predict whether this topography would be an aggressive progressor versus a stable one.
Professor Titiyal, sir.
Kudlu, I have a quick question, and that is, you are predicting post-operatively, whether you can do a PRK or smile or what would be the biomechanics. But at what point in time? I think Praveen was also referring to that. Is it 1 year post-op? Is it 10 years post-op? Is it 15 years post-op? Is it because, see, I think it is very much akin to a Barrett IOL calculator or Taurek IOL, or, when you want to correct that. But that's one point and that's one number. Whereas here, a lot of biological healing, wound healing is involved. Even if you do biomechanics at, say if you do at 1 year, and if you do for a patient at 1 month, it is different. It is not the same.
We have looked at
post-operatively.
Just to respond to your question, the response characteristics that have been programmed into the software are all within the time period of 3 to 1 year. If you are expecting for a response parameter which is beyond 1 year, one of the big challenges that we face is we don't get a lot of patients beyond 1 year follow-up, right? So if now the other situation is that being one center, it's always challenging to feed that much amount of data, but that's also the lacunae. See, with this software, if we can make this available to thousands of refractive surgeons in their OPDs, what normally took us over 3 to 4 years to build to reach this stage would be reached in 1 year, because I'm sure that a lot of a lot among you and even among the audience would have long-term data which can be used and fed into this software to make it even more robust from a further long-term perspective. So that's the ongoing work in progress. So right now we have data here which is in the period of 3 to 1 year of post-operative response.
And
And this is an AI build, so it's a self-learning. So
Yes.
as you keep the machine learns and
Yeah.
it tries to get used to the new normal.
So I would like to add, so for example, in all the tomography machines as of now, the AIs are locked. You cannot feed in your own data, and there is a good reason to do that. Now, if with this software, we get the feedback that give us the option to feed your own data. For example, some among you may have 200 patients right now for which you have 1.5 years of data on Corvus and Pentacam available. We would love to include that in that software and give it to you with that particular AI so that you can have the population database that goes beyond a year. So you have to understand that when you talk about healing,
it will depend, Abhijit, on a lot of factors: the amount of refractive error, the age of the patient, the
of course,
age at which the surgery is done, the age at which the follow-up is 1 year or 3 years. So it is going to vary because biomechanics will vary with age also.
So that's why the AI will work at the back end to link all those parameters into the postoperative. See, right now the AI is not only using the simulations, which is a finite element model, it uses tomography information, it uses age, it uses refractive error, and gives you the prediction. So at this point, I can go on and on that. What at best, like we would like to encourage you to is to use the software and see in your own clinic the accuracy of the prediction, because then only you will realize that how these things work in the backend and give you an accurate prediction.
Abhijit and Rohit, I mean, great work, and really, I think this is the future. But I have one doubt in the sense that I use the Corvus as well as the tomography, the BAT-D, look at the TBI also. Basically, what I do is if anything is wrong, then just play it safe and either refuse surgery or combine it with the collagen cross-linkage. Though the tomography, the pentacam and other things are fairly reliable, as far as the Corvus is concerned, though we are all using it, we have our own reservations about it, the kind of values that it predicts. And for any software, AI-based software, is the quality of data that you feed in which is most important.
Yes.
Are you sometimes, even the biomechanical strengthening that we all accept happening with collagen cross-linkage is not even shown up by the Corvus, and whether PRK, LASIK, or SMILE, which gives leaves behind more strength, that's again the Corvus is not always able to pick it up unequivocally. So feeding in a data from an instrument, which itself is somewhat doubtful as far as the parameters are concerned. If it's a classical concept of garbage in, garbage out. If it's absolutely not accurate, won't it sway the way your software is going to function?
So what happens is the data. Then Abhijit will answer this. The data, what you're feeding in, is not the data as clinicians what we are seeing, and the machine is taking multiple raw data from your Corvus, and it's creating an finite element modeling, which bypasses the deformation or deflection amplitude and TBI, CBI, which we are used to seeing. So because there is one single value which you're used to seeing, that is what we get confused about. And that's why it always tries to make a story around it. So when you create a complete different modeling, which is used in every known machine for whatever refractive procedures, you get a complete different parameters. And that is what he's trying to say. Abhijit, all yours now.
Yeah, so to just add a few more lines. So you are exactly right, Dr. Ramamuthi. See, the difference between what Corvus or Pentacam currently does is they only have AIs running in the background. They don't run classical biomechanical simulations, which are running based on finite element modeling, using collagen features, collagen directions. Those things are not there in the software. Therefore, you are completely, dependent on what, let's say, a location of the cornea gives or what a point on the waveform gives. Unfortunately, that is always going to have some issues. We have also included finite element modeling in it, okay, which is not there in any of the current softwares which are trying to give AI-based predictions. So that is the difference. So this software will not give you answers within minutes. It takes a few hours to run for each eye. Okay, so we do not recommend that this software be used for every eye, for every patient who comes into OPD. We would encourage you to use the software for only those patients who are interested to undergo refractive surgery. Okay, so this will take a few hours to run. So with AIs, you will get answers in minutes. With this, you will not. And just to add a few more thoughts, this is what Dr. Rohit was talking about. So I'm just going to share a figure from the paper from which this has been built. You see the solid lines here are all the actual measurements, and the dotted lines are what the finite element model predicts. So you can see that the level of accuracy that you get when you actually include classical simulations that are derived on tissue biomechanics, you can get much higher accuracies. Unfortunately, AIs will not be able to simulate scientific modeling. They will not be able to do that. They just run regression models. Invariably, you know, whichever AI model is there in the backend.
I had one question, Dr. Rohit and Dr. Abhijit's splendid work. I just wanted to know, after these procedures are done, which model predicted the best, you know, corneal, this thing for maybe for, was it SMILE or was it PRK? Was it LASIK?
Doctor, it was a very nice question, but surprisingly, every single patient had a different way of what it predicted, and that would, and now I've started using in my clinic. And like I said, you know, so earlier you do PRKs for everybody. There are times now I've said that both SMILE and PRKs is showing same amount of weakness. Then you change it to a SMILE. And there are times when you'd say that everything is the same. All the three known methods would differ. And there are times you would say all of them are bad. Then you do go for an ICL. So all this is not going to just done to rule out an ectasia. This is done to actually see, customize it to what you want to do. And in fact, this is not to reduce your numbers. It's actually going to increase the numbers, because you would probably plan it more ethically and keep it more informed.
Thank you so much, Rohit. I think due to the possibility of the time, I think let us move on to the next speaker. I invite Dr. Chekitan Singh. I think he'll be talking about mystery of versatile laser. To introduce him, I think I request Amit Porwal. Is Amit around? Yeah.
I think you go ahead.
Yeah. I'm only inviting, sir. I'm only inviting. Are you able to see, sir? Oh. Yeah. Dr. Chekitan Singh, actually, he's from Rohtak. He's been, I can say he started his career as with UV and vitreoretina specialist. Then now he is also doing, interestingly, refractive surgery. I think he has got a numerous degree, and he has also got a FRCS from the Glasgow Royal College of Surgeons. So he has got a lot of publications, and he has presented in a lot of paper presentation in almost international conference. He has got a lot of publication even in the journal. So it's over to you, Chekitan.
Thank you, sir. So please, can you
stop sharing? Yeah.
Thank you very much, sir, for the kind introduction. I wish to thank the AIOS Scientific Committee, Dr. Partha, Dr. Namrata Sharma, Dr. Krishna Prasad, who has been my mentor actually in teaching me refractive surgery. I learned it from him at Udupi at his center. And I wish to thank Carl Zeiss India Limited for giving me an opportunity to present my views on the mystery of a versatile laser. I have no financial interests. So the unfolding of the mystery started with me going into the details of different companies. In 2016, we wanted to buy a laser. So I went into the details, and I was pleasantly surprised that Zeiss was a more than 150-year-old company. It was one of the oldest existing optics manufacturers in the world. It was a world leader in optics with fundus cameras, microscopes, lenses, lasers, and even semiconductors. We have an association with Zeiss of more than 25 years in our hospital, and it has stood for impeccable quality, value, and things which are built to last. So my wish list for picking a refractive platform was cutting edge technology, which should be clinically relevant, It should have the best optics in business, should be easy to use, should have less recurring costs, should be sturdy, and should have excellent service backup. The cutting edge technology, what I wanted to do was I wanted to compare it, unraveling the mysteries of the competitors. So you can see that the Zeiss MEL 90 is here and all the latest machines which are there in the market are there. So this is the only laser which was dual frequency. It was one of the fastest laser around, although the Schwein Amaris had double the frequency, but the speed of correction was the same. It had a very good eye tracker. It had a flying spot configuration and a Gaussian beam profile, which is required. It had the advantage of offering topo-guided treatment and presbyopic correction, and also offered a femtosecond link. The features which I really admired, for me, the unique selling point was FlexiQuence, which was 250 and 500 hertz switch, which was possible, a good eye tracker, an advanced ablation algorithm, ultra-fast speed, and topo-guided LASIK and presbyon additions, which were possible. There is absolutely hassle-free gas exchange, no nitrogen generator, as the beam is in a vacuum path. And in the last 4 years that I've used this machine, there have been absolutely virtually no breakdowns. My preferred range of corrections have been myopia 8 to 9 diopters, hyperopia up to 5 diopters, and astigmatism up to 4 to 5 diopters. So unraveling the mystery of dual frequency, why do we need dual frequencies? We need the faster frequency or the 500 hertz for standard LASIK, because once you make the flap, the stroma is exposed and there are different ways it can get dry or get overhydrated and can result in different results. So you need a faster laser for standard LASIK, but for 250 hertz, you need a gentle treatment for the surface. And it is postulated that the 250 hertz avoids overheating of the cornea and thus reduces corneal haze and subsequent regressions after PRK. The advanced ablation algorithm which this machine offered was a one profile which fits all. It combines the tissue saving properties of the TSA which was there in the MEL 80 and aspherical optimization algorithm which has been added to it subsequently. It maintains asphericity with still very little tissue consumption. Centration, eye tracking, and angle kappa really gains significance in hyperopic corrections where the angle kappa is slightly on the nasal side. Angle kappa is the angle between pupillary axis and the visual axis. So this machine gives you opportunity to merge the fixation light, which is the eye tracker centration, versus the fixation light green one where the patient is fixating. So you can always, always recenter it so that both are at the same point, and that leads to better corrections and overall better results. The importance of cyclotorsion, especially in higher cylindrical corrections, more than 1.5 diopters cannot be overemphasized. Dr. Dan Reinstein's data shows that. And you can see that for higher corrections, 2 to 3 diopters or beyond, even a 5-degree axis rotation error could lead to an undercorrection of 0.5 to 1 diopter of astigmatism, leading to an unhappy patient. There are two ways to compensate for it. One is the automatic one, which is the oculine feature, which is there with the VASCA analyzer in the Zeiss machine. However, I do it manually with a bubble marker, like you do in the toric IOLs. And then there is a feature called the zero line, which you press. When you press that and the patient is aligned, red laser light is projected onto the cornea and the marks have to be aligned with that light. And I have been surprised that in higher corrections, there have been 10 to 15 degree errors which were there. So correcting that leads to an absolutely stellar performance of the laser and very good post-operative results. And it is already published that manual nimble markings and iris registration software are equally effective and safe. Coming to the presbyon feature, which this laser offers, I think it is one of the most comprehensive presbyopia correcting platforms. Works on the principle of laser blended vision that increases depth of focus by controlled induction of spherical aberrations and by micromonovision. As you can see, apart from the young patient, only the presbyon patient has a blend zone in between, and all other ways of correcting presbyopia have gaps in them and thus dissatisfied patients. The proof of the pudding lies in eating it. So our experience and results with the versatile MEN 90 are here. We did a part of the refractive surgery record analysis, and out of 703 eyes, male and female distribution was pretty equal. The mean age was 22 years, 97% satisfaction in patients, which is really great. for a refractive platform. We did around 38% PRKs and around 62% SBK LASIK. The correction ranged from -0.5 diopter to -11 diopter in myopia and +0.5 diopter to 5 diopter hyperopic correction. Cylinders were corrected up to 5 diopter cylinder, even in the plus range up to 4 diopters. And our experience showed that 95% of the total patients achieved uncorrected visual acuity of 6/6. 99% of the LASIK patients achieved UCVA of 6/6. 90% of the PRK patients achieved visual acuity of 6/6. And if you add the ones with 6/6 partial vision, that is 8%, it goes to 98% for PRK. So slowly we have, started in confusing cases or thinner corneas. We have started doing more and more number of PRKs, which I was really happy to learn that LV Prasad has also data on that, and they have published on it with excellent results. Our experience also with the Moria SBK 1 use plus microkeratome has been phenomenal. From day one, I have adapted to SBK LASIK, creating 100 micron planar flaps with the 90 micron head. Have made flaps in Ks ranging from 40 to 47 diopters, very low complication rates. It has a disposable head with blade, eliminates risk of cost and re-sterilization. Very good flap edges, absolutely no DLKs and no epithelial ingrowths in my cases. Visually insignificant microstria have definitely been observed, especially in the left eye, probably because I'm right-handed. So when we are ironing the flap, sometimes because of thin flaps, it's there, but none of them have really caused vision problems. Flap-related complications have been very fairly low, less than 1%, 2 incomplete flaps and 2 free caps in 4 years, all in the first year. My take-home message would be to invest wisely, especially in the post-COVID scenario. Zeiss has the most comprehensive and upgradable refractive platform as of today. The most number of experience with SMILE is there with Zeiss, and it has already shifted the world. And you will have to price your refractive procedures in these times attractively to achieve viability. Excellent results and commitment to quality alone triumphs. Thank you so much.
Thank you, Dr. Chekitan. I think to discuss this particular about the versatile laser, I request Dr. Sujata Mohan and Dr. Pooja Kamar. Dr. Sujata?
You have to unmute. Dr. Sujata, please unmute yourself.
Okay, it's a very interesting laser. I mean, I really had a look at it before I went in for my FS 200 with Excimer 500, EX500. It has a lot of benefits, as has been very well explained, and I think it all depends on what you are comfortable with and what type of laser you've been using from the beginning. And I mean, MEL 90, I think, is really one of the very best lasers in the market, because it very closely follows very similar to what we are using, the Allegretto. And I'm sure the results will be fantastic with that, though I don't have any personal experience with MEL 90. From what he says, I'm sure he's got fantastic experience. And as far as the microkeratome is concerned, I think the later versions of the microkeratomes are almost all on par. We don't see any of those problems we used to see in the previous era. And I've been using Amadeus for quite some time and hardly had any flap-related complications. It all depends upon how you're using the parameters. And now I think most of us have converted to almost doing 100% femto, so we don't see them anymore. And I'm sure the combination of this microkeratome with the ML90 is definitely an excellent one.
Comments from Pooja?
Yeah, very nice talk, Dr. Singh. But I just want to know from you and the other panelists like Dr. Kudlu sir and all about the topo-guided treatments in MEL 90. How well the topo-guided treatments are, because nowadays everyone talks, even for your regular corneas, for your LASIK treatments, they say you should do a topo-guided treatment rather than just aberration-free or wavefront optimized. So that is one thing I would like to know from you and the other esteemed panelists.
Ma'am, I do not have experience with the topo guided. I'm still going to upgrade because it's 3-4 years now I've been, but Dr. Krishna Prasad, I think, sir, would be.
Yeah, topo-guided treatment we have been doing only in a complicated case like post-residual refractive error or some suspicious case. But apart from that, we have been doing, I don't have MEL 90 laser. I do have got MEL 80 laser, that is a older version. Still, we can do topo-guided treatment with that. Only in the complicated case, I've been trying to do the topo-guided. I think, Sonu, what is your opinion about topo-guided?
I think yes, topo guided we reserve only for basically retreatments or badly scarred corneas, not for all. And there is a lot of noise. I just wanted to raise one question here. A lot of noise about contour vision. So vis-a-vis smile and a lot of this has been talk everywhere. So I think from the experienced senior surgeons, I would just request to pitch in and let us, the public in general should realize, our audience should realize what is the major difference between Contura and Smile. Are we comparing the two technologies on the same platform, or it is just kind of a promotional policy of one over the other? Dr. Mahipal is here. I think Dr. Amrita ma'am.
Dr. Can I comment on that?
Yeah, ma'am, please.
I'm sure people are using Allegretto. Almost all of us are doing the Contura. Dr. Ramurthy and Dr. Rohit Shetty, and definitely it has its value, and particularly in astigmatism over 0.75 and in virgin corneas, definitely it has an edge. And probably, I mean, I don't do Smile, so there's no comparison. So people like Ramurthy and Rohit will be the better judges. And from my point of view, was wavelet optimized versus Contura, there is a definite mileage.
Thank you so much. I think let's move on to the next speaker. I think now we'll really switch on to the overall theme into a case profile. I think the next speaker is going to be Dr. Vardhaman Kankeria. And to introduce him, I request Dr. Fairoz, our dynamic scientific member. Over to you, Fairoz. I'll be just sharing you the
screen share. Thank you, Dr. KP. So far, it's going so fantastic. And it's been a pleasure listening to all the experts on refractive surgeries. So I take this honor and pleasure to introduce Dr. Vardhaman Kankeria, who is a very young, vibrant, excellent cornea refractive surgeon that I have known right from his, post-graduation days. And he has been the recipient of various awards. And in most of the international and national front, he has made us always proud in the excellent talks that he delivers and the scientific content with which he presents his paper. So you have always made us proud, Dr. Vardhaman. And to his credit, he's a recipient of various awards nationally and internationally, and he's a great orator as far as I know. So welcome, and it's a pleasure to have you with us. Dr. Vardhaman, over to you for your talk. Thank you so much.
Thank you very much. Thank you so much, Dr. Fairoz, for kind introduction. And once again, I'll just put my slide on. Yeah. Thank you. So I'm going to keep it quick. First of all, thank you, Dr. Partha sir and Dr. Kudlu for this kind invitation. I'm just going to speak about one of the ways to perform both LASIK enhancement and some experience with that. So we all know that LASIK has been probably the most popular refractive surgery world over, right from its beginning until even today. And of course, compared to its prior preceded, which was surface ablation, it actually definitely provided us a lot of advantages, and those advantages were because of the intrastromal ablation. Now, of course, with the advent of Smile, which is now probably one of my procedures of choice, we have gotten away into a flapless LASIK era. However, when we talk about primary LASIK patients who have been treated in the past, and some of them do require enhancement, from very early days till until now, I think the enhancement rates are now gradually decreasing because we have a better patient selection criteria and also probably the better laser profiles. However, still the retreatment rate for residual refractive errors as well as for regressions are there. And currently there are chiefly three approaches that we look at. One of them is doing surface ablation, re-lifting the same flap, or even de-cutting at deeper level with the femtosecond laser technology. And when we look at the surface ablation, of course, it is one of the simplest ways to enhance a patient. One of the other things that we have to look at is that possibility of phase formation is much higher. If you do surface ablation, you have to use mitomycin C for much longer time. And the epithelial profile is going to be variable, so you should have access to the epithelial mapping. When it comes to the relief with the flap, it is very crucial that you don't disturb the epithelium around, because this relifting is known to cause increase in chances of DLK, epithelial ingrowth, and also certain instances of having microstriae. And the flap lift are known to be slightly more difficult with the femtosecond LASIK procedure, especially after a long time of the primary procedure. So I'm not dwelling into this case, but this was one of the cases that we had published in which after two enhancements which were done elsewhere in Athens, in Greece, actually this patient had developed very, very high astigmatism because of severe epithelial ingrowth. And we had to actually go and ampute this flap. And then we achieved finally 20 by 30 vision. And we had published some time back this in JCRS. So when we look at this thing is basically because whenever we are looking at flap relift, there is much higher chance of epithelial ingrowth because you are entering through the same side cut which was created in the past. What if you create a new side cut and use a approach which is a side cut only approach to relift the same interface and perform a enhancement? So side cut only approach can be performed with the femtosecond lasers, as you know, and especially what you have to do is that you have to create a flap and which is going to be only the side cut, which is going to be created about 1 millimeter inside the previous flap with the same lamellar interface. So you have to go 20 micron deeper and you have to be 1 millimeter smaller as compared to the previous flap. And you have to make sure that you are actually taking care of marking the previous flap edges very well, because you do not definitely want intersection. So this is one of the videos which actually shows with intralays how this is done. You can see these are the markings of this, and this is the flap which is created inside the previous flap. This is very crucial because now you have two side cuts, as you know, and you have to be extremely careful when you enter this interface because the interface is the same. So in this case, you, instead of going with a small lifting of the edge and going with your spatula all around, you have to actually make sure that you have separated this side cut from everywhere, because there is a possibility if you just enter with a spatula without just making sure that you are erupted a new side cut, you can actually enter from the old side cut from this side. So basically speaking, as you can see, once the side cut is done, this is the old interface which is re-lifted back. And then once the old interface is lifted, you just have to go inside and you have to do your ablation. And once the ablation is performed, you have to put the flap back in its place. And yes, this is the end of the enhancement procedure. Always put a contact lens in such scenarios at the end of the procedure. So as you can see, this is the new side cut inside, and this is the previous side cut. This new side cut with the femtosecond laser is very pristine and has been planned well. This can also be done with the Smile or Visumax technology if you go and use the Circle software. If you're using the Circle software, the Type 1 module of the Circle software actually has the possibility of creating only the side cut, and in that you can actually perform the same kind of side cut approach. So we have treated about 11 eyes with this approach with a mean age of 30 years and with a mean corneal thickness which ranged to about 480 microns in this case, and mean pre-enhancement refractive error of minus 1.86 diopters. So this was the pre-operative spherical equivalent. This is the pre-enhancement spherical equivalent, and this is what has been achieved at the end of enhancement. So this was the further one nice report which I had pleasure of actually collaborating with Dr. Praveen. This was a study which we had done in Basam Palmer with Dr. Sonia Yu, and in that we had actually shown with the same approach, if you have to be very, very careful, because if you actually go eccentric in this case, as you can see, you can induce irregular astigmatism, and this was something that we published in JRS in 2013. So basically, this approach is one of the good approaches if you're looking at enhancing a post-LASIK patient, maybe 3 years or more down the line after the primary LASIK procedure, because it is going to definitely reduce your chances of having especially the epithelial ingrowth. Thank you very much for your kind attention. Thank you.
Thank you, Vardhman, for this very nice talk. I would request Professor Tatyal. Sir, are you there? Dr. Rupal, ma'am.
Namrata, you can, Dr. Namrata.
Dr. Namrata, ma'am.
I think
A quick comment.
Very nice case, Vardhman, and very nicely managed. A novel way of managing it, and these cases are always tricky. I think Vardhman did a great job. I can only, appreciate the case that he presented.
Vardhman, a quick question from my side. That was really very wonderful. Your preoperative refractive error showed -5, and you had showed a residual of -3. -3 as your residual. So how do you account for that? I mean, residual being -3.
Yeah, so basically some of these cases have been actually
Can we have rest of the speakers to be on the mute mode?
probably Dr. Right. So yeah, some of these have been actually very, very old cases. Like they are probably older than 10 years or 12 years after the LASIK procedure. And that was like the mean. So basically the primary treatment has been as high as 8 or 9 diopters actually in those cases.
Tatyal, sir?
Tatyal, a quick.
Before I make a comment, I would like to ask Vardhman, a very nice presentation of cases. What about the use of contact lens, which is quite controversial now? Some people say you should put contact lens. Some people say you don't put contact lens. And some people do, de-epithelialization of area before you lift the, flap in these cases. Because as far as I'm concerned, we have done also quite a number of cases where we re-lifted the same flap like we do for routine LASIK. If you manage the flap appropriately, the chances of epithelial growth is there, but quite less. What about using alcohol near the edge area to devitalize the epithelium?
Sir, I think what you have discussed with your experience is quite true, because the mismanagement of epithelium around the edges of the previous flap is the main reason for epithelial ingrowth. And if that can be taken care of by either denuding a bit of epithelium around it or whatever way is possible, probably will reduce it. But because right now it is so difficult to actually have a kind of randomized control study, because this thing is so rare. And nowadays the enhancements have become also very uncommon, and we also approach it with surface ablation many times also. So we don't really come to know. But I know from one thing is that Dr. Praveen had done one study in Bascom Palmer that time, in which they compared the relifting of the same flap and versus the side cut only approach in about, I think relifting was done in about 100 odd eyes, and the side cut only approach was done in about 21 eyes. And they had seen that the side cut only approach reduced the epithelial ingrowth rates statistically significantly in that case. But yes, definitely, I think if it is well managed, epithelium around the edges is well managed, it is possible to relive the same flap, especially less than 3 years after the primary.
Can I make a comment?
Parveen, what about contact lens? What's your idea on that?
So contact lens, so I think I personally prefer to put whenever I have a dicey situation, typically speaking. I typically use it, but I think all others can probably.
A quick comment from
Vardhman, can I make a comment?
Yes, ma'am. Yeah.
Yeah, sorry. Vardhman, wonderful presentation as usual, what was expected from you. Vardhman, I just wanted to say that this limits you if you don't have a femtosecond laser. So, and not everybody in India would have one. And therefore, I think it's also good to learn a technique which will give you a less chance of epithelial ingrowth. And it's possible to lift a flap. I've done one even after almost 19 years without any epithelial ingrowth. So it's also better to learn a technique to open the flap. And once you can master it, even if you don't have sophisticated equipment like a femtosecond laser, because this would now again involve you to use a license.
Yeah.
if you're using something like a circle software, only side cut maybe you will be able to do. You may not know exactly the extent of your flap. Sometimes the flaps are decentered and your side cut may not be decentered because you're centering it exactly. So, you can avoid these situations because otherwise you'll have a wedge at the end.
Right.
If you just can't match it. And therefore, I think it's also good to learn the basic techniques and try to not disturb the epithelium while entering, and you can still do a good job.
Absolutely. Yeah, completely. Yeah.
Thank you, madam. Thank you so much. I think going to the next mystery of cases, I think I invite our dynamic scientific committee member, Dr. Balla, to introduce one of the dynamic young surgeon from Coimbatore, none other than Dr. Anant Doddaramegowda. Over to you, Balla.
Yeah. Thank you, sir. Is my slide visible?
Yeah.
Yeah. Now it's my pleasure and privilege to invite Dr. Anant D, who is a senior phaco-refractive surgeon and assistant medical director at Lotus Eye Hospital and Institute, Tamil Nadu and Kerala. He has a lot of experience of 14 years post PG and has done about 26,000 corneal-based refractive procedures, a lot of topical phaco procedures, and he has received many recognitions like Young Ophthalmologist Award, CME Award at Vienna, and many other prestigious awards. Over to you, Dr. Anant D, for your talk. It's all yours.
Thank you, sir. Start sharing my screen. One more. So good evening, everyone. Hope the screen is visible. So,
Yeah.
Sarve Jano, let us all stay safe during this time. And no financial disclosures. I'm just a high volume phaco-refractive surgeon. So even in spite of doing very high number of surface ablations, I do not have much of haze in my patients where I have subject those patients for the retreatments. So that's why today in this mystery, I will just unlock and try to give some information how I have handled my patient in reducing the haze rather than how I have managed 1 or 2 cases. So over the next few minutes, I will try to explain you the pathophysiology, how I went and prevented the haze and how to identify the haze and how to manage if at all if it's happened, but it's better to prevent the haze in these patients. Haze is nothing but an unwanted adverse effect which typically happens after the surface ablation, and this is usually subepithelial in nature, whereas in CT it happens in stromal. This is subepithelial, and it is typically happens in a predisposed patient because of the exaggerated inflammatory response. The incidence varies from center to center. In my experience, I feel it is between 1 to 2%. And with the age, I think the use of mitomycin, the incidence of haze has literally come down to even less than 1%. And here I should say special thanks to Rohit sir for doing extensive work to identify the novel predictive factors which in a predisposed patients, they have done a good work. What happens is, in a normal, once the epithelium is removed, there is unbalanced level of regulatory factors which contribute to the abnormal fibrotic response, which brings about the excessive myofibroblast formation, leading on to this aberrant collagen deposition and extracellular matrix remodeling. All this happens from the corneal epithelium. So whenever they present in 2 varieties, transient haze and the late onset haze. Transient haze usually starts very early. They are mild in nature and they resolve over a period of months. But the late onset ones, they are more resistant to treatment and they can even persist also. And whenever they appear, they can reduce the quantitative and qualitative vision. Most of the times they present as undercorrection, myopic regression. If the haze thickness varies from segment to segment, they represent as irregular astigmatism, and on topography, they appear simply erratic. So as I told you that to unlock this mystery of haze, my advice to all the budding refractive surgeons is do not choose a patient more than -6 and subject them for surface ablation, because we have so many other options such as SMILE and ICL that remains the better option. The risk of haze increases whenever we are ablating more than 100 diopters, we are treating a hyperopia more than plus 2.5 and astigmatism more than minus 2.5. And whenever the ablative zone is lesser than 5.8, 5.7, the risk of haze increases. And to my notice, and most of majority of the clinicians have also agreed with this, that post surface ablation, whenever the patient goes on a holiday or when he gets exposed to too much of sunlight, the tendency of haze has been increased. So that I have made it in my routine protocol. I advise to all my patients to prevent excessive sunlight exposure for the next 3 months post surface ablation. And one more, what I have noticed, why the haze tendency is less in my patients, because whenever I remove the epithelium, either with my epimicrokeratome or with my LASIK 18% alcohol, I make sure that I have a very clear margin of epithelium. I think this factor also might have helped me to reduce my haze tendency in my patients. And these days, majority of the examiners have do smooth profile and a very minimal spot laser, and all lasers are doing good, and the haze tendency doesn't much differ from company to company. The most important role is of mitomycin. So majority of us, we do use 0.02%, but the duration varies from center to center. But in my protocol, over the last 14 years, I use 0.02. If the ablation is less than 70 microns, I expose it for 15 seconds. If the ablation is between 70 to 90, I go with 30 seconds exposure. Between 90 to 110, I go with 1 minute exposure. And as I already mentioned, if the ablation is more than 110, I prefer not to do a surface ablation, preferably go with SMILE or ICL procedures. And long-term fluoromethyl use for 6 to 8 weeks has got a very good anti-inflammatory effect, and that reduces the haze tendency. Vitamin C has been a routine protocol for all my surface ablation patients. I do feel that I do not have any supporting literature telling that, but to my observation, I feel that vitamin C BD for 1 to 2 months has got a significant effect on the reduction of haze. And each and every PGs are aware of this clinical grading of haze and all. And if at all, if the haze happens, that has to be treated surgically. So as I told, I've treated only 2 or 3 cases where I go with superficial debridement with the use of mitomycin for 30 seconds. Some people do recommend PTK, but I do not have any experience of doing PTK for these haze patients. So this is how it appears. It's better to prevent it. Thank you.
Thank you so much, Dr. Anant. I think now I request Dr. Ramamurthy sir and Dr. Gaurav Luthra for a few comments.
Go ahead, Gaurav.
Okay. I actually went off to sleep for some time.
Dr. Anand, can you stop sharing the screen, please?
Yes, sir. Yes.
But I think this subject is close to my heart, and if we can stop sharing the screen, I can't see anybody. Okay, great. So no, I think fantastic talk, and you've really nailed it, because a few of the things that you mentioned about the UV exposure. In fact, my only haze in 2-3 patients, I would have done high volume of PRK for almost 15-18 years now, and the only couple of cases where we got significant haze was similarly with high UV exposure or early withdrawal of topical steroids, and these 2 things have been the crux. But also I think the management of planning the amount of mitomycin and the steroid regimen, and actually reinforcing the patients each time that they visit for follow-up about the UV glasses. They tend to forget, and some of them actually the compliance with the topical steroids may not be great, and they may continue to use the lubricants and forget one of the other things. So I think meticulous attention to follow-ups and details and discussing and chair time with the patient, with the surface patients, I think is critical. And I think the mitomycin protocols, Praveen uses a very, very rigorous protocol. I tend to use 0.02% for 12 seconds for less than 50 microns, and maybe about 30 seconds for more than that, which is the Majmudar and Randy Epstein protocol, and have been using it for 15-16 years very effectively, and not got haze. Also the few other things with the chilled BSS. So I think it's a whole gamut of things. I think a lot of things go into managing PRK patients effectively, and kind of getting good results. But I think you covered almost everything really well. I'll leave it to Dr. Ramamurthy sir for the final comments.
I think very comprehensive presentation, Anant, and well done. I also agree. I don't generally do PRK beyond -6. But of course, hyperopia we hardly ever do, and not much experience of doing PRK for hyperopia. Maybe 2 diopters is a good limit. We routinely use 0.02% mitomycin C for all our cases of PRK for 30 seconds. And it's only for retreatments or wherever we expect a problem that we go on to 1 minute, and it serves us quite well. The only point I might slightly differ is the longer duration of usage of steroid drops. And there have been occasions when the cornea has remained clear, and 6 to 8 weeks after, when the steroid drops are withdrawn, that's the time the haze comes about. So usually we keep these patients on loteprednol for about 3 to 4 months along with lubricant drops. And it seems to work quite well, maybe just twice a day after about 8 weeks, but then keep it on for a long time. And vitamin C supplementation is something that we give. Occasionally, very rarely nowadays, I think it's not just the usage of drugs, it's also the kind of lasers that we had. The PRK got a bad name mainly because it was the earlier version of lasers that was doing it. Now with the flying spot lasers and the kind of laser treatment that's done, maybe the propensity for haze is much less. I feel that as all of us are realizing, PRK is a great tool, and in spite of SMILE and femtolasic, everything becoming available, whenever I'm in doubt and I still have to do a laser vision correction, I tend towards going towards PRK, and it's always with mitomycin C, and it serves us quite well.
Dr.
My one
Ramamurthy, I had a question. Okay, sorry. Yes,
Yeah.
Dr. Kudlu. Yeah.
One small question to Dr. Ramamurthy, sir. You've been doing PRK for a quite long period. So we've been starting to put steroids from the very next day of the PRK. Then slowly now the things has been changed. Some people are putting that Acuvale soaked contact lens for a period of 5 days. Once the epithelium heals, then you take out the contact lens, then you put the steroid. What is that your take home message? Whether we have to start steroid on the very next day for 10 days, then taper with the loteprenolol?
Oh, first, I just like to correct you. This thing you have been doing for a very long time. Started doing in 1997 LASIK, but for almost the first decade, I used to pride myself with the fact that I don't do PRK. I used to think that it's something substandard to do, but it's only later on with the flying spot lasers, when so many papers coming in, that we started realizing that PRK is a great way to treat refractive errors. And we start steroid. We put a contact lens on the patient, bandage contact lens for 3 days. Starts local steroid drops right from the first post-operative day. The patient is also on topical antibiotics for the first 1 week, and we have not really had a problem with that. I do realize that by the time the contact lens is removed, usually 4 days later, the epithelium is healed up completely. And maybe there is an argument for not using steroids in the first 3 or 4 days, but we have not had any problem with using it right from the first post-op day.
Dr. Kudlu, yeah, I just wanted to chip in by saying that I use Acuvale for almost a year and a half now, and it's been fantastic. I mean, it's really transformed my PRK practice, because patients first day post-op, sometimes, my PRK, post-PRK patients are as good as the SMILE patients. They hardly have anything. I mean, the LASIK patients may have more discomfort than the PRK patients. And we start topical steroid on the table. We don't even wait for the next day. For 15 years, I've been, using topical steroid starting on day 1, day 0. The second thing is that the steroid has to be, I think some people use it for 3 months. We have stuck on a 6 weeks protocol of tapering topical steroids, and we found. I had a question for Praveen. Actually, Praveen tends to go beyond the 100 microns ablation depth, which is my cutoff for PRK, because the only 2 or 3 bad cases I had were those which were close to 100 microns, and all the other patients have had. Is the secret that mitomycin for per diopter, kind of 10 seconds per diopter, where you go for what is the highest ablation that you treat, and how do you prevent haze in the very high depth ablations, Praveen, as you tend to go much deeper than anybody else?
I think first up, really the comprehensive presentation by Dr. Anant, and covering topic about preventing haze very nicely. Two points about what question was discussed earlier as well. Earlier till about 2015, we used to use only topical Nepafenac on the eye along with antibiotics, and then start loteprenolol once the epithelium healed. But then again, because of reports of potential corneal melt with NSAIDs on a bare epithelium, we stopped doing that. And so since then, we've been using loteprenolol from day 1, like you said. And there has not been any difference in the haze between the two groups. We've got about 6,000 cases in either group, and that is actually potential evidence that says that they probably don't play a major role. But for the higher myopes, we've gone up to 140 microns of ablation for PRK. As of now, we've settled around 130. I think we do it pretty routinely, and we have several cases that have had PRK. I think the duration of exposure of mitomycin C probably is the key. So our protocol is about 10 seconds per diopter of correction, and we've been using that. We've got about 11,000 cases so far, and though there have been the occasional haze cases, the number of cases that required intervention for haze in that 11,000 have been only 3, which is really, really low.
And
I have a question for the whole panel.
Praveen, what is the concentration that you have been using?
0.02%, 0.02 standard.
Yeah, sorry, please, ma'am.
Yeah, I have a question for the panel, and Dr. Anand, really a good presentation. I also want to know how many people get their patients' vitamin D in serum levels checked before PRK, and whether that gives some indication of whether this person is going to get haze. Also, the method of epithelium removal, does it have an impact on how quickly the reepithelialization occurs and the haze subsequently? So we have found that transepithelial method definitely scores a little better over the other methods in terms of reepithelialization happening quickly. Is that the experience of somebody else, or is it only mine?
I tend to agree with you, Dr. Rupal, in the sense that we routinely do transepithelial PRK. Now it's one straight shot. I mean, the removal of the epithelium as well as the correction of the power. And definitely, as everyone else has expressed, we find even on the first postoperative day, most of these patients are not too much handicapped. They're not complaining too much. They seem to be reasonably comfortable. And I think we all know that the epithelial thickness is somewhat variable. And the fact that you remove a uniform amount of epithelium on the surface of the cornea obviously exposes you to a better surface for the correction of the refractive error. If you're just removing variable amount of by a mechanical debridement, maybe the thickness of the cornea that's left behind is not going to be very regular. But I'm really surprised at this, your experience, Praveen. I mean, because all of us seem to have to do something. It's maybe the Hyderabad weather or something. I mean, in the sense that most of us seem to have a cutoff of -6, but
it's Praveen's magic.
140 microns, and you say that your experience has been uniformly good. I mean, apart from mitomycin C, is it any other secrets to it?
No, it's also the long-term steroid. I think the lotipred, we are very, very aggressive about ensuring that the patient is using lotiprednol about twice a day for close to 6 months for the higher correction. I think that has been something that we insist at every visit.
No, I think that should be a
take-home message. Do you get the vitamin D levels also done?
Vitamin D, I think if you do vitamin D for 100 of us, 90 of us will have deficiency. So I don't think that's a very good measure in determining who will have haze and who won't.
If I can, Dr. Kudlu, if I can just add a point.
Group probably present.
Somshila, please.
Yeah, we do it for all the patients, ma'am, because there are enough reports and evidences that vitamin D has a role in epithelial healing. It aids in epithelium healing and it reduces the inflammation. And Dr. Anand wonderfully covered that inflammation is linked to post-PRK haze. So we do at vitamin D level for all our patients. A lot of patients walk in with post-PRK haze. We treat them also with vitamin D. Even if I do agree with Praveen sir that 90% of India's population is below the normal range, but then there are enough evidences that it can treat it. So we believe in it.
Somshila.
So my point is just that, first of all, excellent presentation, Dr. Anand. I think he did cover most of it. And just wanted to vouch that Praveen is not the only one. Our entire group pretty much follows the protocol that he laid out for us. And the few cases that we had of delayed haze, they were the ones which had early discontinuation of steroids, if I remember correctly. And so though a couple of them were very high myopes. So I think that in keeping in mind, so you asked what is different about Hyderabad. It seems to be what is different about our population is that the average pachymetry is on the lower side, and we often have to resort to PRK for this reason, and slightly irregular topography sometimes. And the last reason being a lot of them are software professionals, may not afford SMILE, and we want to not do LASIK. And ICL or IPCL are expensive surgeries. So I think that PRK works pretty well in our hands, even for these high myopes.
Dr. Somashela, hello?
Yes, yes.
Do you find, what is the percentage of problems with mitomycin C in your PRK patients? Do you find any downside to using mitomycin C?
So I think I'll be superstitious and touch wood, knock on wood, that so far we've not had any downside that we can attribute to mitomycin C usage.
Thank you so much.
I have one question for Dr. Praveen, sir. Sir, I have been doing PRK, and recently I've been doing more and more PRK, and after attending Refractive 360, seeing LVP data even more now. So I actually had a problem that I also put loteprednol on the contact lens. We start on the first day, but say around 2 weeks or so, the haze starts coming in, when the epithelium is healed, everything is there. So I have now found that probably that time, if we still continue with loteprednol, it doesn't go away, or the patient remains dissatisfied. However, at that point of time, if we stop loteprednol and start Predfort 4321 weekly taper, they become subsequently okay by 4 weeks, and then we put them back on loteprednol. Is that your experience, or maybe we are not treating it in the right way?
No, I'll say a couple of things. Interestingly, because we have a wide number of surgeons, we have some variability in protocols as well. So what we've found is that if you use a faster laser, we have a MEL 90 in our network. We have a Allegretto, we have 2 Allegrettos actually. If you use a faster laser, the amount of haze probably is also more, probably because of the fact that the cornea doesn't have enough time to cool down in between the ablation. But this, like you correctly said, tends to peak in the first month. But after that, naturally, it tends to go down. And I would probably say, irrespective of the kind of steroids you use, because we have one member of our faculty who uses Predfort hourly, immediately after PRK, and then switches on to lotepred later on. Well, I've seen a patient who had haze after that as well. So I don't think it is about the intensity of steroids, but I think it's about the duration of persistent steroid use, which probably makes a difference.
Thank you so much, Praveen.
He's right, actually, because I use only FML. I don't even use loteprednol, and my incidence is probably the same.
Thank you. Thank you so much. Thank you so much, Gaurav. Over to you, Sonu.
So I'll now like to invite Dr. Parikshit Gokte, our dynamic scientific team member, to please introduce Dr. Hari Prasad. I'll do the slide.
Thank you, Dr. Sonu. Can you share the slide for Dr. Hari Prasad, sir? Yeah. Dr. Hari Prasad is a young star, and he works in Shankara Nethralaya, Shimoga. It's one of the most beautiful hospitals that I have visited, and he's an expert in refractive surgery. He's passed from Bangalore, and he has numerous papers and awards in refractive surgery to his credit. So over to you, Dr. Hari Prasad, sir.
Thank you, sir. Thank you, Dr. Parikshit Gokte. But a small correction, sir. I work with Dr. Krishna Prasad Kudlu in Prasad Nethralaya.
My apologies.
Thank you, sir.
Can you share your screen? Can you able to?
So can you see, sir? And is it visible?
No.
No, it's not.
Share your screen.
I'm trying.
Dr. Hari Prasad, the green button on the bottom on the screen, you need to click on it.
Yes. Yeah. Thank you. So at the outside, I'd like to thank AIOS Scientific Committee and Carl Zeiss for giving me this opportunity. Today, I'll be talking about some interesting cases in presbyon. So as you know, presbyopia is irreversible loss of accommodation, which happens during aging. And nowadays we have many surgical approaches which correct presbyopia. But even then, management of refractive errors in presbyopia remains quite challenging. Coming to the specific topic of laser blended vision, also called as presbyon, it uses the principle of micromonovision with increase in the depth of focus. Micromonovision is planned initially by making the non-dominant eye myopic by 1.5 diopters, and the dominant eye is made plano for the distance. Depth of focus is increased by two factors. One is by the natural pupil constriction, which is maintained or retained even after the loss of accommodation. Next is by increasing the, or inducing the, I should say, inducing the controlled corneal aberration in both the corneas. So when there is micromonovision, along with increase in depth of focus, patient is able to see clearly both the distance, intermediate, and the near. As in any other surgery, more so with presbyon, patient selection is the key. So you need to see the patient's visual needs, occupation, and the daily tasks before selecting the patient for presbyon. Now I'll be discussing about 3 cases which have undergone presbyon with us. All 3 have different refractive errors and visual needs. My first case is a professional photographer. He's 47-year-old. His dominant eye is right eye, and he comfortably accepts the monovision trial with the spectacles with 1.5 diopters. As you can see, is myopic. Right eye has a refraction of around minus 3.5 spear and minus 0.5 cylinder, 180 axis. Left eye has refraction of minus 2.75 spear and no cylinder there. Pachymetry is quite adequate, around 535, and cornea is keratometry is quite regular. I'll be telling about the results at the end. Now coming to the case number 2, he's a businessman, owns a retail chain of retail stores here. His main motivation to undergo the procedure is he doesn't want to look a day older. And he came to us saying that he doesn't want to wear any glasses when he started to feel the need for near vision glasses. So we tried evaluating him. He's a 42-year-old, right eye being dominant. And he too accepted the monovision test with micromonovision test with the glasses for 1.5 diopters. As you can see, he's almost immetropic in right eye. The refraction being plus 0.25 spear and plus 0.5 cylinder at 70 axis. In left eye, it is plus 0.5 spear, that's it. Pachymetry is quite adequate, around 520 microns, and keratometry is quite regular. Coming to the last case, we have a politician who is quite dynamic. He's a local politician, very outgoing and dynamic. His main complaint was he kept on losing his glasses whenever he went to his function or any rally. So he didn't want to use his glasses. So we evaluated him. He was a 51-year-old person. His dominant eye was right eye, and he too accepted the monovision test with 1.5 diopters. He was a hypermetrop. His refraction in right eye was plus 2 diopters and a cylinder of plus 0.75 at 90 axis. In the left eye, it was plus 1.75 spear and plus 0.75 cylinder at 90 axis. Again, the pachymetry was quite adequate and corneal curvature was regular. Before I tell the results, I want to make something very much clear. All these 3 patients accepted the monovision trial very well. They were very much comfortable with their distance and near vision. All were well motivated to undergo the procedure. And on examination, there was no intraocular abnormalities, like even the early changes of cataract or any retinal abnormalities. And the surgical procedure went uneventful. So I was expecting a quite similar results in all of them. But to my surprise, the most happiest person was the photographer. He came back to us after 3 days of the surgery with sweet box, telling that he was quite happy with the vision and he has never seen the thing so clearly in his life. Next came the businessman, even though he was slightly unhappy in the immediate post-operative period, especially for the distance. But at the end of 3 to 4 weeks, he adapted very well and had a very good distance, intermediate and near vision. Last came the politician. He was quite unhappy actually in the immediate post-operative period because his main complaint was he was not able to see the crowds in the rallies or a function he went. So he was very uncomfortable and kept on coming back to us telling that his distance vision is quite blurred. And it was quite a hard time for us to convince him that everything will be all right. We kept on reassuring him. And thankfully, at the end of 3 months, he adapted really well and his distance and the near was quite very well. And this was the trend that we have been observing in our center. Most of our happy patients are the myopic presbyopes, and then came the emmetropic presbyope, and lastly came the hypermetropic presbyopes. So when you compare presbyon with other surgical procedure treating presbyopia, patient who underwent presbyon ultimately had very good distance, intermediate and near vision, and they adapted to the procedure very well. And if at all, in the rare case of reversibility, presbyon is very easy to reverse also. You can just treat the dominant eye and correct whatever the residual refraction is there. So I can safely tell that probably the presbyon is the best presbyopic treatment available till date. And it makes your patients quite happy. Thank you.
Thank you, Dr. Hari Prasad. Now I request Professor Namrata Sharma and Dr. Pooja to give short comments.
I got disconnected in between because of network issues, so I did not. I was not there for the presentation.
Pooja?
I think brilliant presentation, Dr. Hari Prasad. We do know and we have heard from a lot of experience of Dr. Kudlu sir and Dr. Shri Ganesh sir that presbyon works wonders. I just have one quick, one small question of even for your myopic patients, sir, you would prefer doing a presbyon or you would prefer doing a monovision for myopic patients?
Yeah, that's what I told. I mean, in our setup at our center, we have been doing presbyon since last 6 to 7 years. And the happiest patient for us in presbyon have been myopic presbyopes. So they've been consistently giving good results. Came the emmetro presbyope and lastly the hypermetropic presbyope.
Okay. Thank you.
I think Pooja, just to add on to this, actually this presbyon, I really don't know. Mine was probably the first soft, almost around 8 to 10 years before.
Yes, sir.
8 to 10 years before I got. So that time, my results with my software with the myopes, it's really working very well. But if you ask Dr. Ganesh or Sheetal, they say that their hypermetropic presbyopes really do well. Probably your pre-op evaluation and topography finding, PACI, all factors come together and make sure that patient doesn't have cataract. All these points come together, then come to a best results.
So when you brought the point out of cataract, I completely agree with you. Why I asked the question was for the same reason, sir, because a lot of them say that for myopic patients, you prefer doing a monovision. For hypermetropic, your presbyon works well. But when you came to the cataract point, a lot of these patients are between 40 to 50 years of age, and you cannot on slit lamp examination see any cataractous changes. So is there any other way you would like to rule out the lenticular aberrations, or you would just go ahead and do a presbyon?
You need to have eye trace equipment with you actually to get a perfect reading. If your eye trace gives that there is even earliest of the cataract, you should never pick them for the presbyon treatment. Then if the patient, after the presbyon treatment, I think I've been doing last 8 to 9 years. Now patients, 1 or 2 patients are start coming to us with the cataract. So what to do next? So what we do, we normally we go to the ACRS calculator and the regular how you do post classic cataract, this one IOL power calculation, but we put them non-aspheric monofocal lens in the both the eye by keeping the non-dominant eye 1.5 diopter myopic. If you put the 1.5 diopter this one to the non-dominating eye, then after the cataract surgery, still the patient will have the good near vision even for a good distance vision. That's what we observed.
Okay.
Kudlu, I just want to rephrase this question. Do you have any upper limit for doing presbyon? For example, I don't do presbyopic classic, but of late I've started doing reasonable numbers of clear lens extraction, and I think especially for 50-year-olds, high probes, and I use the eye trace, look at the dysfunctional lens index, and go ahead and do it. And especially with the current crop of trifocals, extremely happy patients. So is there a say 48, 50, where you would say that I stop doing presbyon and look at the lens? Because as Pooja asked, the lens is defective, and maybe replacing it with the current quality lenses would be solve the problem for the patient on a long-term basis.
It's very good question, sir. I'll just give an example of one of the Swamiji. He is around 64 years old. He doesn't want any of the intraocular surgery. That time I did not had eye trace. I have to send him to Bangalore to get his lens dysfunctional index. Then they said that there is hardly any cataract. Then I gone ahead with the presbyon, but not adding the plus 1.5 adapters. I little bit increased to 1.75. So 1.75 add in the non-dominant eye plus some amount of spherical aberration in that particular eye. That means patient will have a near vision effect of around 2.25 to 2.5. The patient was very happy. Once again, as far as the refractive error is concerned, for hypermetropic, I don't pick them more than 2.5. That is my upper limit, sir. If they are having +3, +4 diopter normal, I don't advise them for doing for presbyon. Rather, I consider them for trifocal or extended depth of focus lens. But for myopic, if they're around up to -4 or up to -5, -6 diopters also, I prefer to do a presbyon than the clear lens extraction.
Any age limit?
If they don't have the cataract.
Any factor?
No, sir. No age limit, sir. Only thing is patient should not be having cataract, sir.
Right. Okay.
Thank you so much, sir. Let us come to the last part of our presentation. One more young, dynamic surgeon is waiting to show his talent. None other than he's from Orissa, Dr. Praveen Subadhi. To introduce him, I request Dr. Somshila Murthy.
Good evening, everyone. Again, it's my privilege to be part of this meeting and to introduce my friend, Dr. Praveen Subudhi. And interestingly, Praveen, it's really nice to see you at this forum, having last met you a while ago when you came to train with us for DSEC. He's a chief consultant at Ruby Eye Hospital, and he also did his cornea fellowship from Arvind Eye Institute from Madurai. And he has numerous publications and presentations. He's also a journal reviewer. And he also won the first prize at the AIOS quiz competition in Jaipur. So I hand over to you, Praveen, and eager to listen to your case.
Thank you, madam, for the kind introduction. Can somebody tell me, are my slides visible and am I audible?
Yes, your slides are visible.
Yeah. So as madam said, my name is Dr. Praveen Subudhi, and I have been in clinical practice. I'm in private practice for last 7 years, since 2013. And my LASIK machine, I installed my LASIK machine in 2015. So there are, everybody will agree with the fact there are certain life-changing moments or life-changing cases which change your thought process in approaching the case and make you realize that why did I take the decision at first hand, and we need to be more careful while taking these cases into for surgery and for other purposes when you see similar type of cases in the future. The similar thing has happened to me in this case where I saw it was in the first year of my installation of LASIK machine. A 25-year-old male came to me with a defective vision in both eyes. He did not have any significant medical or a family history of keratoconus, and his refractive correction was -2 diopters and -3 diopters in the left eye. His myopia was pretty stable for 2 years, and pentacam showed the normal parameters. As it was in the first year of my installation, I was a little bit reluctant to perform PRK in these cases. I was more aggressive in doing LASIK. And this is the pentacam you can see here. The things are pretty okay in the keratometry. The cornea is more regular, and the anterior float and posterior float doesn't show much of any elevations. Only the thing is that there was a little bit of thinner pachy of less than 500 microns. But having said that, because it was a -2 and a -3 diopters, having a residual stromal bed of 350 microns, I thought that it will be pretty safe for this patient to undergo a microkeratom LASIK. And this is the Bellins. Apart from everything is normal except in the bad D in the left eye, it showed a little bit of suspicious. But otherwise, other things were pretty normal. The anterior float and the posterior float elevation, everything was normal. And even if you see the keratometry K1 of 42 and 43 and Kmax of 44, doesn't show any clinical signs of any form of suspicion where I should not perform a LASIK. So I scheduled for both eye microkeratom LASIK. I usually do a 90 micron flap. And it is the flap thickness is quite predictable in Moria microkeratom SBK LASIKs. And the residual stromal bed was around 350 microns, as I said. The surgery was very uneventful, and the post-surgery patient had a pretty good vision of 6/6 in both eyes. Patient did not come to me for 3 years, and he was doing very well for 3 years. Later, here in 2019, he came to me with this picture. Now you can see here there is an inferior steepening, and there is elevation in the posterior float of 36 in the right eye, and posterior elevation of around 47 in the left eye. So to my utter surprise, the patient which had a normal cornea before surgery and post-surgery, after 3 years, the previous patient was fine. He had 6/6. He told me that he was pretty good. But after that, he started developing defective vision, and there was a progressive loss of vision. And this is the Bellin Ambrosio. You can see everything is red, and it is not a rosy picture for me. And because as I'm in private practice, it is very difficult to handle these cases because you are answerable to them. And when I saw this picture, I was a little bit worried what to do next. There was a little bit of progression, and patient had a UCV of 6/36 in the right eye and 5/60 in the left eye, a very highly unsatisfied patient. He had a right eye refractive error of -2 with -2. So the patient which had corrected -2 has developed again -2, left eye with 2.5 and 2.5 at 160. So I thought of doing some amount of corneal regularization with a topo-guided PRK and a partial fluency CXL. The main aim for me is to just to regularize the cornea and to prevent further progression, because these cases may progress. I think, but listening to the talks today, Dr. Rohit Sethi has said that these cases may be stable after a certain point of time and doesn't require any treatment. But still, I went ahead with this topo-guided PRK and CXL. The patient had some amount of regular cornea with an unaided vision of 6/12, but still not that happy, but a relative satisfaction. So my journey after this case, I had stopped performing LASIK, and I have instead I'm performing more frequently PRK nowadays, and this pachy is less than 500 microns. And now I have learned to say no to the patients whenever I see any suspicious cases, whenever I feel that these patients may develop any form of ectasia later on. I have developed a strong in my heart to say no. And even if there is a suspicious cases, I wait for a minimum period of 3 months and see whether there is any stability is there or not, whether there is any progression is there, and then I perform these cases. The most important thing the message I would give to the audience is not to get tempted, and not to be greedy in performing refractive surgeries. So thank you very much for the kind attention.
Thank you, Praveen, for that very nice presentation. I'll request Dr. Tyal, sir. So are you there, sir? Dr. Tyal, sir?
Yeah, listening.
Yeah, sir. Please.
I think it was a wonderful, session for last 2.5 hours. I enjoyed every bit of this, especially the, case presentations by, our young people, and a lot of thought-provoking cases. I think that is what I think this webinar was meant for, and it totally, given us so many things which maybe, has to be highlighted for a better outcome. And I understand, there may be a lot number of.
I think there's a lot of disturbance. Sunilji, can you please mute everybody else, please? Yes, sir.
Sorry.
Yes,
Is it
sir.
better now?
Yes, yes, sir.
Sorry, I think there's something running in my. I think it is, we had so many numbers of, webinars on refractive surgery. Despite that, we need to have more and more such webinars where we need to discuss cases. And cases are the one which are going to give us an ideas how to improvise subsequent outcomes in our patients. And today we had such a wonderful cases. I believe that, it does matter, what will be your experience or number of years you have done refractive surgery. But one case will change your thinking process. As the last presentation by Subhadis told us, like one case changed the thought of entire refractive procedure. I may be doing refractive procedure for last, 2 decades plus, but one case will change my concept, my thinking, that will make you to, think in a different direction. I think that is what I learned today, and it was wonderful program for my entire scientific committee. And congratulations to all the presenters, especially discussions, and I appreciate Dr. Ramamurthy being there. And his inputs are really amazing, and especially, whatever webinar I had opportunity to listen to him. He's such an experienced person, and his points are very well, appreciated by all of us. Thank you again.
Do you think at this point of time, it is what Dr. Abhijit and Dr. Rohit had presented that needs to be chip in relation to Praveen's talk, sir? Do you feel that?
But it is, I think the requirement of time also to have such type of things coming up for a future, safety or procedures. The safety has to be not only for patients, safety has to be for us also. So these things are required for a future, we can't go with the same idea. The new thing has to come to make things more safer, especially for, giving a protocol for a right outcome for our patients. I think that's the future.
So I think choosing the right patient is what is more important for
yes,
a particular.
That's correct. And even that vitamin D things, I appreciate that, and these are things which most people, we don't do it. But yes, we need to assess this patient very, very appropriately also. And hardly matters, one test, and that might give you so many other information, especially if you are doing a surface procedures.
Comments from Sujata Mohan, madam?
Unmute yourself.
I think this has been a wonderful webinar, and we have learned a lot, particularly, the completely different aspect of Rohit's presentation. I think tomography is slowly on its way out, and we have to look at more investigations before we take up procedures. And one more thought is that, like Rohit said, we don't see that many ectasias. And if I do see an ectasia in a patient we don't expect to have an ectasia, then you have to probably find out whether the patient has any comorbidities like eye rubbing, or the patient could be on OCP or things like that, something which could lead on to an ectasia, because those are the very important things that could probably initiate an ectasia, because nowadays we don't see many of them because of the strict protocols we are following. And that's about it, I think. And thanks for the wonderful opportunity, and really enjoyed the whole webinar.
Thank you, madam. Due to heavy rains and sandstorm, I think, unfortunately, Dr. Stream Salam could not able to join us. It was a little bit unfortunate part of us. He called me at least 5-6 times. Please do something. I want to join, but still could not able to join. And in the end, final comments from Dr. Ramamurthy, sir. He's been encouraging this young budding refractive surgeon. Ramamurthy, sir.
I think it's a wonderful webinar, and I learn every time I attend one of these. The small points is not the buying of a great equipment or big, expense that helps you to perform better, but small bits and pieces that you pick up all along. And I think Praveen's presentation in the end was extremely important. It's always, in refractive surgery, it's always better to be safe than sorry. In the sense that, it's not statistics which matter, but these patients are coming with normal vision with just a requirement for glasses or contact lenses. In case of any doubt at all, and if you feel you may be doing something which might harm the patient, just stay away. I mean, the patient can live a whole life with just glasses on. But of course, having said that, I would say that, 25 years back, even before we knew that iatrogenic keratoplasia was a term, we just used to leave behind 200 microns of corneal tissue in the bed. And we must have had a flood of keratoplasia if we hear all this, but it has just not happened. So there's a lot more to it than what we presently understand. Of course, relevant research is going on. But whenever in doubt, play it safe. And I think that's the message. And excellent presentations from the youngsters who came towards the end. I learned a lot. Thank you so much.
Finally, over to our chairman scientific, Dr. Partha Biswas.
Thank you very much. I think, sir, I mean, all of you staying together and till the end, that itself speaks greatly. And I think each one of us have learned from each other, the youngest to the most experienced, as well as what has been said. One thing that is very important for all of us to remember is refractive surgery is actually a mystery. There are so many things that we never knew we did wrong, yet nothing went wrong. So everything is so mysterious. And the mystery to get unraveled is going to take years and years and years. But the future definitely shows that one thing after the other, the nuances that have to be taken into account. And it's such an evolving science. It's a very, very exciting and a refreshing science indeed. And thanks to all our seniors, to all our young colleagues who have made this webinar such a big success. And thanks to Zeiss, who has sponsored this webinar and has been a real pillar, because without finances, nothing moves. And of course, thanks to Mr. Kripal, Pallavi, and Sunilji for being the back-end people and the spine and the strength of all these webinars. Thank you, everybody. Thank you, all panelists. Thank you, all chairpersons. Thank you, speakers, and the wonderful 2 moderators.
Yeah, they've been great. I think, refractive surgery, as said, rightly said, is a mystery till you perform yourself. Yeah. And you subsequently create more mysteries when you started performing more cases.
Yeah.
Thank you, sir. Thank you so much.
Thank you very much, sir.
Thank you. Congratulations, scientific committee.
Thank you very much.
Kudlu and Sonu, great job.
Yeah.
Thank you. Yeah, great job done by Dr. Kudlu and Dr. Sonu.
Yeah.
And the committee, Partha keeps the committee so well knitted, together, and doesn't allow anybody to go out. You may not be doing refractive surgery like Firoz. She has to be there throughout the entire 2.5.
Otherwise, we will not be there in our oculoplasty webinar.
All the best to all of you.
Thank you, everybody.
Thank you, sir. Good
Very
night.
nice.
Thank you
Very
so
nice.
much.
Great job.
Thank you, sir.
Thank you.
Bye-bye.
Good night.
Everyone, have a lovely weekend.
Thank you.
Thank you, sir.
Thank you, everyone. Thank you.
Thank you.